Just making sure you can hear me before we start. We're going to get started in 1 minute. Can someone confirm they can hear me?
I can hear you.
Okay, perfect. All right, we're going to get started in 1 minute.
Cool. Do I put my video on when we start? Or is that
You don't need to yet, Mark. As soon as we get to your slides, you can turn on right at that time, actually.
okay? Fine, Rishi. Thank you.
Yep. All right, welcome everyone to this Real World Data Summit. This is in collaboration with iVista Medical Education. This is our second year for the summit. Thank you all for joining us. The Real World Data Summit came out of a lot of thoughts around how we're doing analysis in ophthalmology and working together to understand disease mechanisms, pathogenesis, risk stratification, and the future of ophthalmology. So thank you all for joining us today for this program. My name is Rishi Singh. I'm the one of the organizers for the course program. I'm at Cleveland Clinic in Florida. And my program colleagues today are Dr. Durga Borkar and Dr. Brian Vanderbeek. And today's activity will actually focus on electronic health data record from data sources in the real world. We're going to evaluate how artificial intelligence and machine learning algorithms use real world images. We'll talk about some of the real world studies and some of their outcomes and how they're impactful for us. We'll have live Q&A, so please ask questions. There's going to have a Q&A box, and we'll be able to get to your questions during the program. And then we're going to also explain some of the practice gaps and some of the opportunities in real-world data. Obviously, this is not a perfect science, and we're going to learn from each other today, and hopefully that will then stir on additional research and education and obviously initiatives by all of us on this program. This is supported from an independent medical education grant from Regeneron, Genentech, and Topcon. Thank you for the sponsors. As mentioned, I'm Rishi Singh from Cleveland Clinic in Florida. Again, Dr. Durga Borkar from Duke Eye Center is going to join us later in the program, as well as Dr. Brian Vanderbeek, who's at Shea Eye Institute in the University of Pennsylvania, and they'll be moderating different sections of today's program as well. We have a very exciting faculty panel lineup, and here are the names as you can see, and I'm going to just flip through them, but because you're going to meet all of them as time goes on. And again, please, this is live, so feel free to ask questions of them, and they're going to be presenting some of their data, some of their analyses, and some of the work they've been doing in this field up to date. We are also want to thank our sponsors for this program, Genentech, Regeneron, Apellis, Astellas, and REGENXBIO. Thank you for sponsoring this program, making it possible this year. And again, the Q&A icon will be the way to ask questions during the talk. So let's get started. So for today's first talk, we're going to have the section of Introduction to Real-World Data and Data Sets. I'm going to be the moderator. And for the first talk, I'm going to turn over to Mark Gillies. He's going to talk about the Fight Retinal Blindness project, collecting data in mandatory pre-specified minimum outcome set data. Mark?
Thanks, Rishi. Mark Gillies here from Australia, where it's 1 o'clock in the morning. I'm talking about our approach where we collect a mandatory pre-specified minimum outcome set, which produces much higher quality data than are often available in our field. This is where the funding comes from for the project. So we take it very seriously, observational studies in Australia. This statement by the Australian Commission on Safety and Quality says that registries are viewed as an important part of healthcare safety and quality improvement, a patient and consumer right, an essential professional requirement, and a health data custodian obligation. So there's 3 ways to collect real-world data. One is pharmacy-sponsored studies. These are expensive. They tend to have a lot of exclusion criteria, and they don't produce great quality data. An example of that is the Luminous study from Novartis. And then the approach taken generally throughout the States is mining electronic medical records by the IRIS system, which gives you very large amounts of data, but generally of lower quality. And then we've been advocating a structured collection of a minimum outcome set, such as in the Fight Retinal Blindness project. So in our field, we're looking at the outcomes of the faricimab, but this has come out, of course. The Truckee study only really has 24% of eyes that originally identified had follow-up after just 3 injections. So 3/4 of their patients had dropped out. And the far wide and the far retina studies from the UK and the USA, they also lost 2/3 to 3/4 of their patients through 1 year. This produces relatively low quality data, and there's a limited amount you can do with that. The approach that we've taken is firstly to identify that everyone agrees on the minimum essential data that we're going to collect. And that's important because it reduces the data entry burden, but also it simplifies the analysis because everyone agrees from the outset what the important variables are that we'll be tracking and analyzing. And then we choose outcomes that patients care about. This is the approach taken by the International Consortium of Health Outcomes Measurement, or ICHOM. That's an American, Swedish organization, which is actually many specialties in America attend the ICHOM conference, but you don't see a lot of ophthalmologists there. I was on the chair of the panel that identified their outcome set for macular degeneration. It now costs about $300,000 to produce one of these outcome sets. It's quite expensive. And they have a one-year Delphi process where they have a panel of international SMEs and lay members, and they drive consensus on that panel. So we have 8 outcomes for the macular degeneration module, one of which is the date. Then we have visual acuity of any annotation. It's automatically converted to logMAR letters. We grade the subretinal fibrosis and atrophy, either present or not, center involving or not, and that carries forward from one visit to the next. Then we grade lesion activity, and we've introduced a subretinal fluid only because a lot of people in Australia do that, and we believe it protects against atrophy. Then, of course, we have the treatment given, any procedures such as cataract surgery, adverse events such as intraocular inflammation in particular, and what the reasons for discontinuing treatment were if it was discontinued. And then the other important point is you have to somehow finalize the data so you can make sure it's all there. So we have a finalization tab once it's all gone through, and the system checks to see whether the data are 100% complete and within pre-specified ranges. Then it goes into the system so that we know that all the data in the database is 100% complete and in range, and we have finalization rates of about 95% for all data. You can save the data and finalize later if you prefer. So we have in our current analysis for faricimab, we have about 100% complete data of 88% of eyes, 88% of 380 eyes 1 year after starting faricimab. So it's a much smaller number, but much higher quality. So we track everything the trachea, far wide, and far retina track. And we also had a separate analysis of the lesions were active or inactive at switch, and they're 2 very different groups with different visual acuities and vision outcomes. We have detailed data on the interval change, which is important because that's the main benefit, particularly in switching. We have a detailed analysis of the course and the outcomes of the 18% of eyes that switched back off faricimab, and we have more information on the adverse events. So to conclude, we're having this conference because there is a growing demand for observational data to check if treatments that passed randomized clinical trials actually work in our patients in real-world practice. We think that the current low-quality observational data can be improved by introducing these 2 important steps. Firstly, you pre-specify the minimum essential patient-centered outcome step that everyone agrees to track, and then you implement a finalization step that ensures that all the essential fields from every visit are filled out. Implementation of these 2 steps will allow our treatment outcome registries to very quickly establish whether new treatments fulfill the promise that they have from clinical trials and how they may be refined. So if you'd like to join the practice, we don't have a lot of Americans in this, but we have a lot of Europeans and a lot of Asians, and there's some contact emails there for you to get in touch with us.
Thank you, Mark. That's great talk, and we'll get to Q&A, so we won't keep you up too late. So thanks for joining so late in Australia. But I'd love to hear that you're open to other collaborators across the world, and that we'll hopefully get some notoriety from this program today. So then I'm going to turn over to Preeti Rao. She's going to talk about real-world intraoperative surgical parameters in the Eye Intelligence Cloud, a national surgical database of US VR surgeons. Preeti?
Thanks so much, Rishi, and for having me be here today. So I want to switch gears a little bit and talk about the surgery world. There's a lot of data on our medical world, but let's switch gears a little bit. So let's see here. So these are my disclosures. So really I want to introduce the Intelligence Cloud database and kind of talk about the overview of current surgical parameters in this database and talk about potential future uses here. So large-scale clinical databases exist for surgical outcomes, but these are mainly based on clinical parameters, as was noted in the prior and future presentations. But the black box is what actually happens during surgery. The problem is we don't really have baseline intraoperative measures to really quantify surgery outside of our operative notes and our amazing surgical videos. So the question is can we really establish intraoperative surgical parameters to be able to serve as biomarkers for and link them to clinical outcomes? So the iTelligence, as I'm going to refer to as the cloud, is a national surgical database of Solaris machines in the US, and this links to their intraoperative surgical parameters. And so in this database, they collect various surgical parameters, which I'll talk about in a second. So these are kind of the baseline surgical parameters that that are part of this database, including infusion pressure, coagulation, laser settings. And what we wanted to do is to really define the baseline surgical parameters in this cloud database and really identify specific surgical parameters that really correlate with potentially duration and complexity of the cases. So this was a retrospective review of all surgical cases in this cloud database. We included all cases requiring a vitrectomy between 2018 and 2024. And the exclusion criteria noted above, but no vitrectomy. And what we've had a sample size of 100,000 cases, 75% were less than 1 hour and 25% were greater than 1 hour. The mean case duration was about 32 minutes in those that are less than 1 hour and about an hour and a half for those that are greater than 1 hour. And basically what we found in the surgical parameters is that the average infusion pressure is about 47 millimeters of mercury, which a pneumatic cut rate about 6,000 and a vacuum time about 392. When we break it down into cases that are less than 1 hour versus greater than an hour, you can see that cases that take less than 1 hour tend to have a higher infusion pressure, higher cut rate, and lower vacuum time compared to those that are greater than 1 hour. Then we wanted to look at markers of complexity. And so one marker we thought was looking at is infusion pressure. So the mean infusion pressure is 47.5 millimeters of mercury. This is not to be confused by intraocular pressure, and this tends to run higher in this particular machine compared to other machines. And when we break it down by greater than less 1 hour and greater than 1 hour, we found that surgical cases that are less than 1 hour tend to have higher infusion pressures. Then we wanted to look at the percentage of cases that actually use the elevated infusion pressure function. And we found that cases that took greater than 1 hour, those percentage of cases were higher in using the elevated infusion pressure function compared to those that took less than 1 hour. And then when these cases were at the elevated infusion pressure, we wanted to know the absolute value. And we found that cases that took greater than 1 hour tend to use higher elevated infusion pressure values compared to less than 1 hour. And when we're at this elevated infusion pressure function, those cases that took greater than 1 hour tended to be at this elevated infusion pressure function twice as long as those that took less than 1 hour. So we wanted to look at other additional markers on complexity. So we ended up looking at a subset analysis of all vitrectomies using endolaser and coagulation. This is about 35,000 cases. And this is a complicated slide, but it's a correlation matrix using Spearman correlations. And what we found that longer case duration was associated with longer vitrectomy time, longer coagulation time, longer laser, and higher laser energy. And shorter cases was associated with higher vacuum pressures and shorter vacuum times. So these surgical parameters based on timing of surgery was very similar to the total number of cases. And when we look at the infusion pressure, same thing. Cases that took less than 1 hour tend to have lower elevated infusion pressure function for a lower absolute value and a shorter amount of time. Then we looked at laser settings. Those that cases took less than 1 hour tend to have a higher power, lower duration, and a lower total energy. And same with the coagulation settings. Those cases that took less than 1 hour had a higher power and lower duration. So in conclusion, we really wanted to define the baseline surgical parameters in this cloud database, and we think that case duration may reflect case complexity. And really, the implications are we really want to create a standardized national surgical parameters and really correlate that clinically to RD repairs, macular hole closures, and which is what we're doing as subset analysis. And really, the future directions of the study is really link this to IOL masters, OCT data, and the phase 3 is to link it to the EMR data. And so I wanted to thank my collaborators on this project.
Great. Thank you, Dr. Rao. So stay tuned for the Q&A. And we're going to turn over to Dr. Tom Chula. He's going to talk about the Vestrum database and its capabilities, and we'll hear from him now.
Today I'm going to discuss the ins and outs of EHR databases, focusing on the Vestrum Health Retina database. My disclosures are shown on this slide, none of which are relevant to this presentation. I'm very excited about the potential for real-world data in ophthalmology. Today I'll briefly cover why is real-world data important, claims data versus EHR data, common current databases focusing on the Vestrum Health Retina database, Vestrum services for industry, and finally Vestrum services for physicians, including some of my own learnings from performing research with this system. Given the ability to scale, real-world data is important for numerous applications, including natural history studies, benchmarking for practice improvement and value-based care, clinical research including retrospective studies, clinical trial site selection and patient identification, as well as providing commercial insights. While claims data may be well structured, EHR data provides important clinical nuances and details. EHR data is generally rich with history, exam findings, and treatment details. The IRIS registry is the nation's first comprehensive eye disease clinical registry. All U.S. Ophthalmology Academy members in good standing are eligible to participate in the IRIS registry. Recently, Retina Consultants of America and Retina AI announced a collaboration to develop a real-world evidence database. Another EHR database is the Vestrum Health Retina database. It includes 2.4 million unique patients and 18 million patient visits from U.S. retina practices. Importantly, as a retina specialist database, it differs from the IRIS registry, which includes all specialties. Today I was asked by the program committee to focus on the Vestrum Health Retina database. The Vestrum Health Retina database includes a panel of over 350 U.S. retina physicians, and it is geographically diverse. Like the IRIS registry, available data includes patient history, visual acuity, intraocular pressure, exam findings, diagnosis, and treatment. The Vestrum Health Retina database de-identifies data and aggregates it in a HIPAA-compliant, secure fashion. It provides various data-driven products such as market research, industry analytics, and physician practice information. I will cover some of this in the next slides. There are various services for industry. First, for commercial and market access, it offers a comprehensive view of the retina landscape, enabling companies to track shifts and changes over time. In health economics, outcomes research, and medical affairs, it reveals the incidence, prevalence, and comparative effectiveness of treatments and supports outcomes analysis for specific treatment regimens and clinical conditions. For clinical trial recruitment, the database helps identify ideal physicians and patients, streamlining recruitment efforts. There are also multiple services for physicians. One service of note includes a recruitment acceleration program which mines practice EHR data to identify potential patients for a specific trial. In general, approximately 80% of inclusion and exclusion criteria can be automatically queried across the EHR data, resulting in a highly accurate estimate of patient recruitment targets. The recruitment acceleration program reports can be sent at a predetermined frequency directly to the practice. This is an example of programmable eligibility parameters of both inclusion and exclusion criteria for a typical wet AMD clinical trial. In addition to clinical trial recruitment, the system provides benchmarking reports, allowing for monitoring of key practice metrics in comparison with regional and national benchmarks. Finally, I want to focus on clinical research. As we discussed, the Vestrum Health Retina database provides information on patient volumes, procedure volumes, medication use, and outcomes data. Physicians can access the data needed for review, analysis, and research. For example, using this system, I've previously presented and published on clinical practice outcomes in over 100,000 patients with neovascular AMD, DME, and RVO-associated macular edema. We've noted that, first, visual acuity gain at 1 year is worse than randomized clinical trials, and that anti-VEGF injection frequency plays a large role in visual acuity outcomes. Second, better baseline vision increases risk of central vision loss. And third, RVO patients experience greater 1 year gain than AMD and DME patients, but show a larger gap in visual gain when compared to respective randomized clinical trials. A limitation of the EHR-based systems involves a key endpoint, visual acuity. In practice, visual acuity is often measured via a Snellen chart without standardized protocol refractions. The formula shown here is often used to convert Snellen visual acuity into an ETDRS approximation, but this obviously cannot compare to a standardized ETDRS protocol refraction. Importantly, I want to point out that clinical research using EHR databases has additional limitations beyond the non-standardized visual acuity. These studies are retrospective with limited controls, which cannot be compared with randomized clinical trials. Furthermore, there's limited ability to tailor inclusion and exclusion criteria compared to the explicit criteria in randomized clinical trials. In summary, there's great potential for real-world data in ophthalmology. These systems can generate important services for industry, for commercial and market access, health economics outcomes research, and medical affairs. For physicians, these systems can also generate important services including clinical trial recruitment, practice benchmarking, and clinical research. Thank you very much for your attention.
All right, and we're going to definitely be able to get to the Q&A with him as well at the end. I'm going to turn it over to Dr. Flora Lum to talk about the Intelligent Research Insight Registry, IRIS Registry. Dr. Lum, thank you for joining us.
Thank you very much, Dr. Singh, and thank you so much for all the wonderful presentations to date. I have no financial disclosures. I'm going to talk about the IRIS registry. It was developed by the American Academy of Ophthalmology for the purposes of quality improvement, first of all, to improve outcomes. And sorry about that. We wanted to provide physicians with individual feedback and be able to compare to benchmarks. And importantly, it helps practices meet the merit-based incentive payment system requirements. To date, there are about over 15,000 clinicians from almost 3,000 practices across the United States. We have 700 million visits and about 80 million unique patients. And in terms of analytic activities, we've been the recipient of several grants now. We have 2 National Eye Institute grants looking at developing a pragmatic registry trial as well as big data analyses. We also received 2 diagnostic excellent grants from the Council of Medical Specialty Societies. In addition, we have a 6-year running grant with NORC, which develops the CDC Vision and Eye Health Surveillance System. We also received an FDA Broad Agency Announcement grant looking at the IRIS registry to look at pediatric IOLs as well as artificial intelligence. And we reported on those earlier this year. We also sponsor our own investigator award programs, Research to Prevent Blindness, Bruce E. Spivey Foundation, the Dunbar Hoskins IRIS Registry research, as well as a Knights Templar for pediatric ophthalmology. We also have the IRIS Registry Analytics Center Consortium, which consists of academic medical centers, and we've presented over 250 times at meetings, both in the US and internationally. And this is to date, we have about 133 publications. What's great is that we've involved a lot of ophthalmologists and data scientists, so over 360 co-authors and across 32 journals, and about over 2,000 citations to date. And you can see below the subspecialty focus, retina is about a third of our articles, followed by cataract and glaucoma. And then the funding has come from grants. In about a quarter of the cases, the Academy sponsored about 20%, in the consortium, the academic medical centers, about 40% of the studies, the articles, manuscripts to date. So I wanted to present a few of the studies and what we've learned so far. So this study, we looked at over 400,000 eyes with acute posterior vitreous detachment. About 10,000 were diagnosed with delayed retinal break or detachment, and the median time was about 42 days for retinal break and 51 days for retinal detachment. And we found that the risk factors were vitreous hemorrhage, history of retinal break, lattice degeneration, myopia. And this has led to from a recommendation from OMIC, our insurance company, or affiliated insurance company, that patients should be seen within 42 days from their initial posterior vitreous detachment. Another study that we've looked at was viral anterior uveitis. So we found that only 2% actually get an anterior chamber paracentesis or TAP. But when it was performed, it also changed the diagnosis in 42% of the cases. So the mean delay was about 51 days. So the delay meant that people were not getting appropriate treatment and likely subject to corticosteroid treatment as well. We also looked at loss of follow-up. So we had about 156,000 patients during this time period, and we found about a 12% loss to follow-up. And again, risk factors include increased age, male sex, unilateral involvement, Medicaid insurance, and race and ethnicity. And that was also published earlier this year in Ophthalmology Retina. And this is an analysis that we did during the COVID period to look at what would we expect. And so we were able to use the IRIS registry to estimate what we would have expected to see in terms of utilization on a monthly basis, because we've had several years of data prior to this. So you can see in the green, those are the expected, and then you see a very sharp drop in 2020, obviously March, April 2020, where we don't see the utilization for these different patients with glaucoma. And you can see in the red, that's where the red is where we saw the greatest drop in utilization or visits. And then you can see here, this dotted line is where we'd expect to see patient utilization would be 1-to-1 to what we expected. But you can see those conditions that are closest to what we would expect are the more urgent conditions, like wet AMD, obviously, proliferative diabetic retinopathy. Those were the patients that came in, but the patients like glaucoma suspect or cataract, they did not come in for visits during this time, which would be expected. And thank you very much. I think that big data. Oh, go ahead. Sorry.
Go ahead. No, please conclude. Let's go ahead.
Oh, I was just going to say, yeah, I think just that real data aggregated electronically has really allowed us to understand the natural history of disease, diagnostic and treatment patterns, comparative treatment outcomes in a relatively efficient and cost-effective way. And it doesn't, as previously said, replace randomized controlled trials, obviously, but it does augment our understanding. Thank you so much.
Yeah, thank you. Thank you, Dr. Lum. So we're going to bring all of our panelists back up for the discussion portion of this section. And really great presentations by each of you. I think the one question that came up from an audience member is watching right now is sort of how recent the data is. So maybe each of you can comment on sort of the most, how recent the data would be. Is it 6 months? Is it a year old? Is it 2 years old? How about Mark? We'll start with you, then go to Preeti, and then to Dr. Lum as well.
We pretty much get it in real time. So, I'm talking about 400 patients that have been exposed to faricimab. We get the data as the data goes into the database as the patient's seen.
Yeah, same. So it's really nice. So it's whenever the surgery is done, it's uploaded in the cloud and you have access to that data.
Okay. Dr.
For the
Long?
IRIS registry, we integrate the EHRs, and we have to wait for the records to be finalized. So it's about a 3-month turnaround. So we have data now, through 2024, about August.
Great. Dr. Rao, when you look at some of the surgical parameters, that's a very interesting overall study and way of capturing good data. The diagnoses aren't captured right now. Is there a plan in the future to capture some of the diagnoses, or at least have a pick list so that people can understand better?
Yeah, absolutely. Great question. That's the goal for our next phase, is to be able to link it to diagnoses. What's nice now is that, like, if you have practice data, you can link it to your own patients, which is what we're doing for our retinal detachment outcomes. But yes, that's the next phase.
Okay, great. And this one is for Dr. Lum. Accessing the IRIS registry, for example, for industry, is it possible is it only going through Verana Health, or it does go directly to IRIS? Can you explain that sort of work?
Sure. So Verana is our exclusive partner for commercial pursuits. So yes, it is through Verana Health.
Great. And in each of your groups, I wonder if you could kind of explain. I know Dr. Lum explained this very well, so maybe for Dr. Rao and Dr. Gillies, how would one go about asking a question or submitting a question to the group to the sort of answer? Maybe Dr. Rao, start with you first, and then we'll go to Dr. Gillies.
Yeah, I was actually just talking about this with the marketing team. I think it would be great to do something similar to the Iris, where there's a grant you can submit. But right now, it's very informal. I mean, if you have a question, like, go to your local reps and your local medical team, and they'll be able to do it, which is really nice. So any physician can ask those questions right now.
Okay. How about Dr. Gillies?
Yeah, we have a similar approach. Anyone who's actively entering data in the system is allowed to propose an analysis. We have a publications committee which reviews that. And, if we think it's a worthwhile thing to do, then we go ahead. We do the analysis ourselves for them. We don't give them the data, but anyone can propose an analysis.
Dr. Lum, I know Dr. Gillies explained about the ex-US collaboration, and maybe you and Dr. Rao want to answer. Are there ex-US collaborators as well, or is this truly just a US-based kind of collection system to date?
For the IRIS registry, it is purely US. We've had issues, I think, with all the different privacy laws and EHRs in different languages, so we have not gone outside of the US.
Yeah, same. So currently it's just US surgeons, but I think there's an opportunity to provide more international collaboration depending on where the machines are used.
The trouble is that elsewhere in the world, you don't have the interoperability that you have in the States. That was one of the features of Obamacare. He made all the health records interoperable. They hadn't been up until then anywhere, and that's one of the things that they introduced in America. So it's actually, it's a great place to collect observational data.
Excellent. Last question from the audience member, and we'll go to the next section. Talking about imaging integration, each of you has presented a little bit on that, and I'd like to hear kind of each of your perspectives on how you're planning, if at all, to integrate imaging into the next kind of phase of the studies. So maybe Dr. Gillies, we can start with you.
Yeah, we're doing that. We have to individually consent patients for that, but then we're uploading the images into the cloud and developing algorithms to assess those, and we can then merge the imaging outcomes with the high quality clinical data sets that we have for deeper insights into disease mechanisms and outcomes.
Dr. Rao?
Yeah, so as mentioned earlier, BNL has partnered with Heidelberg, which is a really nice, unique opportunity to be able to link the OCT data. So that's definitely the next step. But obviously, we, in platforms outside of Heidelberg, I think that would be more of a company collaboration. But I think having Heidelberg partner with BNL is going to be a great future collaboration.
Okay, and Dr. Lum?
And likewise in the IRIS registry, we've collected a few million images and we're actively collecting them now. And on the other front, we're also pushing a lot on the vendors for DICOM standards so that we are able to exchange images a lot more easily.
Great. Awesome. All right. Well, thank you all for the presentations. Really fantastic to see all the data sources that are available, again, surgical and medical and imaging forthcoming, if not already available. So great to see all that. And with that, I'm going to turn over to the next session for Dr. Vanderbeek, and he's going to start off for us.
Hello. Welcome to session 2 of age-related macular degeneration. Thank you everyone for joining us. And again, thank you to our sponsors. First up in this session, we will have Farhina Ali talking far retina, 1-year visual acuity and anatomical outcomes.
Great. Good morning, everyone, and thank you for the opportunity to present this 1-year data from the far retina AMD study. These are our financial disclosures. And so as we all know, faricimab, and we've already talked about it earlier today, was available since January of 2022. It is the first bispecific antibody. And since then, we've had several real-world studies looking at faricimab treatment patterns and outcomes, including those that are listed here, many of which you may have already learned some of the data reports from, but also including Roche-sponsored prospective and retrospective trials. Let's see here. Okay, and so the far retina AMD study is a retrospective real-world study in which we use the IRIS registry in order to understand those early treatment patterns and outcomes for these patients. And you already heard an excellent introduction this morning from Dr. Lum about the IRIS registry. But in terms of our methodology, we looked at documented diagnoses of neovascular AMD with known laterality during a specific time period of having received at least 1 injection, with at least 12 months of data prior to that and 12 months of follow-up data also available, in addition to visual acuity measurements and a subgroup analysis looking at anatomic parameters, as you can see listed out here. And so here is the cohort that we have. And so applying that criteria, we have a treatment naive cohort and a previously treated, almost over 2,100 eyes in treatment naive and almost 27,000 eyes in those patients that were previously treated. And you can see that between the groups, it was relatively well balanced in terms of treatment naive and previously treated. And we see that the demographic is quite typical, as might be expected for neovascular AMD patients. And what we found was that approximately 2/3 of the in the group that were previously treated had been switched from aflibercept, and their mean injection frequency in the prior 12 months was approximately 7 injections, on average 6 weeks apart in that prior 12-month of data to initiating faricimab. And so those patients that did begin use with faricimab, they had vision of 20/40 or better, and that seems to be quite consistent with clinical trial enrollment data that we've seen over the past recent years in terms of patients sort of being treated earlier and presenting earlier as well. In terms of vision improvement, here's what we saw in the treatment naive and previously treated. So for those eyes that had no prior treatment, we saw good vision improvement, as might be expected. Previously treated eyes maintained stable vision, as you can see on the right. And in a small cohort of patients that had vision of worse than 2,200, we did see vision gains both in treatment naive as well as the previously treated eyes, greater in terms of 8 to 14 letters for treatment naive compared to 5 to 6 in the previously treated. Sorry, I think I went ahead there for slide. Okay, in terms of anatomic parameters, we saw good central subfield thickness improvement both in treatment naive and in the previously treated eyes, highlighting potential in terms of the specific molecule that we're using here and any additional gains that we're seeing anatomically. More than 50% of those NAMD eyes achieved an extended interval, that is what we defined as greater than 6 weeks, within 2 initial injections of faricimab. You can see the proportion that were previously treated as compared to treatment naive, slightly higher in terms of previously treated, likely speaking to confidence in switching these patients and known patients that the providers were using this drug on initially. Now, in terms of number of injections, so fewer injections were seen in the latter 6 months as compared to the first 6, indicating rapid extension. And you can see treatment-naive eyes as well as previously treated. Interestingly, when we looked at this data as compared to the faricimab treat and extend arm of the Tenaya and Lucerne trials, we saw that this was quite similar. So in other words, in the allowance for variable treatment intervals, we're seeing what was mirrored in the clinical trials in this real-world data cohort using the IRIS registry. So of course, we're going to be interested in the safety profile in general in the real world, but certainly with any new product, new molecule. And we saw low rates of intraocular inflammation and endophthalmitis. And this is the pooled data for both far retina AMD and diabetic macular edema. And I'll give you just a moment to look at those numbers. But the rates were low and not exceeding those that were seen in the clinical trials. Okay, so in total, the findings from the far retina AMD study, the AMD cohort, do support real-world efficacy, durability, and safety of faricimab for the treatment of neovascular AMD as compared to also what was seen in the clinical trials. There are definitely going to be limitations associated with electronic health record data, as has already been discussed a little bit today, and the audiences of this session would be quite familiar with. There are no standardized measurements or physician dosing frequency rationale that are available in terms of when we look at this data in aggregate, and the current data don't necessarily reflect any future treatment patterns. In terms of effectiveness and outcomes, we did see vision and CST improvements in the treatment-naive eyes, stable vision and CST reduction in previously treated eyes, and fewer injections from 6 months onwards, suggesting efficacy and treatment interval extension. In terms of safety outcomes, there was an overall incidence of IOI and endophthalmitis that was low and consistent with those previously reported in the faricimab phase 3 clinical trial program. So thank you very much for your attention.
Thank you, Dr. Ali. Next, we have Maida Hedzimitovic talking about Visudyne use for neovascular AMD and impact on anti-VEGF treatment intervals.
Hi, everyone. It's a pleasure being here today. And on behalf of my colleagues and myself, talk to you about the photodynamic therapy in the area of injectables, especially is there still the room for the photodynamic therapy in the treatment of neovascular AMD. I'm consulting for Bausch & Lomb, producer of Visudyne. So this is my patient that we have been following for years, treating every 4 weeks, could not extend, good visual acuity. We did FA ICG. On the FA occult leak. On the ICG, we saw branching vascular network with the feeder vessel. We did the PDT. And 3 months later, you can see that actually branching vascular network is getting smaller. There is resolution of the fluid and more consolidated fibrovascular PED. We preserved vision and decreased injection burden. This is another similar patient that actually had more robust branching vascular network and feeder vessels. You can see a large fibrovascular PED, spongiform subretinal fluid. Post-PDT, you can see that actually branching vascular network has decreased in size, consolidated fibrovascular PED, and resolved subretinal fluid. We preserved the vision, and we decreased the injection burden. I just want to remind you a little bit about the fluorescent and ICG differences. So fluorescence is only able to analyze the fluorescence coming from the retina, as the RP blocks the signal, while in the case of the ICG, we can analyze retina and choroidal near-infrared fluorescence, which is not blocked by the RPE. At the level of the choriocapillaries, we can see aggression of the ICG from the fenestrate choriocapillaries, and thus FA assesses the retinal leakage, while the ICG is for morphology and flow that actually we use for targeted PDT. We started using verteporfin photodynamic therapy back in the 90s as a treatment option for multiple choroidal diseases. And then in 2001, it's proven to be more effective than placebo in the treatment of neovascular AMD. And then actually we were using that treatment up to the advent of the anti-VEGF. Now we have amazing treatments with great durability. So the question is there a role for the PDT in the area of injectables? So when we talk about the mechanism of the photodynamic therapy utilizes a photosensitive agent called verteporfin that accumulates in the retinal pigment epithelium cells and abnormal vessels, having high affinity for the choroidal vessels. After activating verteporfin with laser energy, we have actually productions of the free radicals that stimulate local cytokine production in the endothelial cells, and thus we get series of the events. We get vasoconstriction, we get thrombosis, we get hypoxia, and vasoocclusion of the pathologic blood vessels. Management of the neovascular AMD has been a hot topic and still is very hot topic. We started treating the neovascular AMD in 90s with a cold laser. Then actually we started doing injectables, and big boom in 2000, where actually we started getting anti-VEGF treatment, very successful treatment. So we actually went a long way from 70s when we coined the term of the choroidal neovascularization and angiogenesis to now, where actually we have very successful and longer duration treatment. So how I see the treatment of the neovascular AMD, this is a multifactorial disease. And nowadays we're actually trying to target multiple pathways at the same time. Intravitreal anti-VEGF injections are the standard of care, very successful standard of care, but there are patients who are not good candidates if they're elderly, if they don't have good family caregiver support system, if they have tachyphylaxis, if they don't like injections, and there is very slim risk of the infection with the injection. The question is, what are the effects of the combo therapy? Anti-VEGF therapy targets the key mediators of the angiogenic cascade, and verteporfin targets the vascular component, mostly choroidal. Adding synergistic corticosteroid treatment post-PDT provides anti-inflammatory, anti-fibrotic, and anti-permeability properties, and these different mechanisms are very good to actually provide better success in the treatment, that actually we can increase the duration in between the injections. So we were asking whether there is enough of the literature support to tell us that actually verteporfin PDT in combination with injections makes sense. And we did 2 studies. We did a meta-analysis, about 3,000 patients from 23 studies, and we did IRIS registry study that actually had about 414 patients. Objectives for the meta-analysis were visual outcomes and changes in the frequency of the anti-VEGF injections in patients with neovascular AMD undergoing the treatment. Primary outcomes: best corrected visual acuity, macular thickness, and number of the intravitreal injections. When you look at the best corrected visual acuity, at the baseline, we didn't have the difference, but 12 months later, best corrected visual acuity was significantly better in patients that were co-treated with the PDT and ranibizumab. Then when we look at the central macular thickness, neither at the baseline or at the endpoint, we didn't have significant difference. And then when we were looking at the number of the injections, we actually had a significantly reduced number of the injections in the anti-VEGF plus PDT treated group for all injectables, ranibizumab, bevacizumab. We could not actually estimate for the aflibercept because the numbers were not good. Then we did the IRIS registry study. We evaluated the visual outcomes and changes in the frequency of anti-VEGF injections in patients with neovascular AMD undergoing co-treatment with PDT. This is going too fast. Selection criteria are shown here. So neovascular AMD patients co-treated with the PDT, time period 2017 to 2021. We were using IRIS registry, and we were actually comparing frequency of the intravitreal injections and the visual acuity. This is actually just a little bit about the selection. About 414 patients met inclusion-exclusion criteria. You can see their demographics on the right hand. And this is a busy slide. I'm going to try to cut it back. The increase in the injection interval between the verteporfin PDT and the first post-procedure anti-VEGF injection was about 35 days. The average injection interval between anti-VEGF injection increased from 4 days at the second injection to 14 days at the 9 injection. In all, we actually had about 2 injections less if we co-treated patients with the PDT. So in the conclusion, I'm so sorry that the slides are looking like this. They were not looking like this for me. So meta-analysis showed decreased injection burden and improved best corrected visual acuity. And IRIS registry showed that there is actually significant decrease in the injection burden without improvement in best corrected visual acuity. So the common denominator is that if we combine injectables with the PDT, we can significantly decrease the injection burden, but the patients have to be selected appropriately. So I want to thank everyone, Durga, for leading the IRIS registry study, Verana Health. I'm grateful to Bausch & Lomb and people who are working with me on the meta-analysis, including Sunir Gar from Middlesex Hospital. Thank you so much.
Great. Thank you. Next, we have Sumit Sharma discussing retinal vasculitis with or without retinal vascular occlusion among eyes with neovascular AMD or DME treated with intravitreal agents as recorded in the Vestrum database.
Thank you. And I'd like to thank the organizing committee for the opportunity to present the results of our work. Of note, for my financial disclosures, I am a consultant for Genentech and Roche, which sponsored this work, and Regeneron, which is the subject of this work. So we know that the antivascular VEGF agents have been the standard of care for both neovascular AMD and diabetic macular edema, and that retinal vasculitis with or without occlusion is a serious adverse event that can lead to pretty severe vision loss and has been reported in patients treated with anti-VEGF agents. The US labels for faricimab, ranibizumab, and aflibercept, both the 2 milligram and the 8 milligram, were amended to include information related to retinal vasculitis with or without occlusion after approval, after these cases started to be seen. So we conducted this analysis of the Vestrum database to improve the understanding of safety and figure out the rates in the real world of retinal vasculitis with or without occlusion in this setting. So we aim to find an incident number of cases of either retinal vasculitis with retinal vascular occlusion or other etiologies in patients who had either neovascular AMD or diabetic macular edema that were being treated by an anti-VEGF agent as recorded by individual clinicians. This is a retrospective observational study using data from the Vestrum Health database. We looked at patients over 18 years of age who'd gotten at least one anti-VEGF agent from January of 2014 through March of 2023, following their initial diagnosis. We excluded eyes that didn't have visits following their index injection date, and eyes that had a history of either intraocular inflammation, retinal vasculitis, or retinal vascular occlusion prior to their index injection date. We were looking for three types of AEs: retinal vasculitis with retinal vascular occlusion, or intraocular inflammation with retinal vascular occlusion, which included patients with retinal vasculitis. The three types of AE were assessed separately and were assessed using the ICD-9 or 10 codes. And the case definitions for retinal vasculitis with retinal vascular occlusion and intraocular inflammation with retinal vascular occlusion required you to have a combination of diagnosis codes, which could have happened on different dates, but the date that both of the diagnosis codes were met and the complete case definition was met was the date that was used for the indexing. Patient eyes were followed for a maximum of 180 days after each intravitreal anti-VEGF injection until the first event was ascertained, and they weren't followed anymore after the first event. We assessed AEs up through September 30th of 2023, and we're expressing the number of events as an N and a percentage of exposed eyes based on each of the individual anti-VEGF agents, either faricimab, 2 milligram aflibercept, ranibizumab, or brolucizumab. Overall, there's 300,940 eyes that received 4.27 million injections across all four agents. And when we look at it, we kind of walk through this table, and then I'll show you each of these in graph format. So when we look at the first one, the retinal vasculitis rates, we see that the overall exposure for faricimab is about 23,892 eyes. For aflibercept, it's 200,386 eyes. And for ranibizumab, it's about 135,167 eyes. And for brolucizumab, about 4,700 eyes. If we look at the event rates in terms of percentages, we see that the overall percentages are very similar between faricimab, 2 milligram aflibercept, and ranibizumab, but significantly higher for brolucizumab for retinal vasculitis. Again, similar findings for retinal vasculitis with retinal vascular occlusions, where there's a very low event rate for faricimab, 2 milligram aflibercept, and ranibizumab, but a significantly higher rate for brolucizumab. And then cases that have either intraocular inflammation, this includes those with retinal vasculitis, so the previous category, with retinal vascular occlusion, we can also see that there's a very low percentage rate, so the very bottom row, for faricimab, 2 milligram aflibercept, or ranibizumab, and a significantly higher rate for brolucizumab. Here's that same data shown in a table format, and I'm sorry that the numbers come up so much smaller here, but we're looking at brolucizumab is all the way on the right, We have faricimab all the way on the left, 2 milligram of aflibercept is second, and the third one is ranibizumab. And the overall rates for faricimab, 2 milligram of aflibercept, and ranibizumab for retinal vasculitis are low, but significantly higher for brolucizumab. For rates with retinal vasculitis with a vascular occlusion, again, very low for faricimab, 2 milligram of aflibercept and ranibizumab, but significantly higher for brolucizumab. And then finally, those with intraocular inflammation with retinal vascular occlusion, again, very low for faricimab, ranibizumab, and 2 milligram of aflibercept, but significantly higher for brolucizumab. And all of the brolucizumab rates were statistically significantly higher compared to either faricimab, aflibercept, or ranibizumab, and there was no statistically significant difference between faricimab, aflibercept, or ranibizumab for any of these. And so in conclusion, we're seeing that there's a higher percentage of eyes treated with brolucizumab that have events compared to the other approved anti-VEGF agents. There's a number of limitations here because the sample size differ between the agents. There's wider confidence intervals for some of these groups. And the estimates may have been limited by surveillance bias. And these are not validated through individual case review. This is just based on ICD-10 code. So it really depends on what the underlying physician coded. The analysis didn't account for varying duration of exposure for eyes, nor did it account for correlation between eyes if they were from the same patient. And you could have had misclassification of events to agents if the eyes received multiple agents. And the events may be underreported or misclassified in electronic health records, but it does give us some information and some thought in terms of what is happening with the different agents and the rates that we can expect to see with the different agents. Thank you.
Great. Thank you. Next, we have David Eichenbaum giving us an update on pegcetacoplan for geographic atrophy clinical studies and real-world experience.
Brian, thank you for inviting me and introducing me, and I appreciate Durga and the entire iVista crew for putting this event together. I'm David Eichenbaum from Retina Vitreous Associates of Florida, and we're going to talk about pegcetacoplan, clinical studies and real-world evidence, focusing on the real-world evidence. The Gale 36-month extension is the longest time point we've seen in the Oaks and Derby registration trial. We see a reduction in lesion growth up to 42% in the 24 to 36-month time period in the extension trial. Over 90% of patients who started Gale finished the first year of the Gale extension study. So this is encouraging data. The safety profile in Gale is similar to what we saw in the parent studies, with no evidence of non-occlusive retinitis nor vasculitis in the extension study. An interesting analysis performed was the time to experiencing severe vision loss, defined by the World Health Organization as 20/200 or worse. And we saw persistent vision loss for at least 4 months at that point, reduced significantly when patients were exposed to pegcetacoplan in a dose-dependent fashion, with monthly pegcetacoplan showing a significant reduction in the occurrence of this adverse event. What we see is consistency also amongst these various post-hoc analyses, and we'll revisit those shortly. The takeaways from Gale are that there's a favorable benefit-risk profile to pegcetacoplan, 42% reduction in growth, delayed progression to severe vision loss, and there have been over 420,000 real-world and clinical trial injections administered now, with safety staying consistent with a 1 in 10,000 per injection rate of vasculitis, 1 in 4,000 first injection rate of vasculitis. Microperimetry is something that's been looked at. This is a post-hoc analysis which was performed looking at the central 4 and 16 loci in the junctional zone, which was where we believe the activity is in geographic atrophy, where the pathology is happening. And what we see here is that there was a trend towards favoring pegcetacoplan, both in the central 4 and pressure tested in the central 16 loci in that area, showing that pegcetacoplan does seem to reduce the rate of the junctional zone loss when you expose the patients to pegcetacoplan. In a prospective analysis with a pre-specified endpoint, this was essentially emphasized and duplicated. We saw for the first time in this relatively new data set that when patients were exposed to pegcetacoplan at month 36, at the bottom, with the monthly group, we had the endpoint and the confidence interval favoring pegcetacoplan for a reduction of scotomatous points on microperimetry. So this is a big deal, the first functional benefit that we've seen in a geographic atrophy treatment. Takeaways from microperimetry are that this can be clinically meaningful. This is a pre-specified visual endpoint, both in a post-hoc and a prospective analysis. We saw a reduction of vision loss related to the microperimetry consistent with RPE and photoreceptor preservation in eyes treated with pegcetacoplan. Let's talk about some real-world data here. There are two parts to real-world data. My friend Sam Miniker is going to dive deep into his real-world data, and what we have here is data that was presented as well at the American Society of Retina Specialists by Jan Singer-Ravellu, and what she saw in this PRISM analysis looking at Retina Group of Washington, New Jersey Retina, and RCC were about 1,451 eyes with geographic atrophy treated with pegcetacoplan. About a third of these eyes had neovascular macular degeneration, and 2/3 were pure non-neovascular with geographic atrophy. These patients are old. They're over 83 years old on average, and they're white, with over 85% of them being Caucasian patients. What we'd expect. We saw here in follow-up that these patients had at least 7 months of treatment on average, with the vast majority of them showing over 6 months of treatment. We saw that in the patients who had previously received anti-VEGF injections, that they continued to receive anti-VEGF injections at about the same rate. We saw that the interval remained stable for those patients receiving anti-VEGF injections, and patients with quiescent choroidal neovascularization did show a trend towards recurrence when exposed to pegcetacoplan. Looking at adverse events in the real world is something that we're especially attuned to in retina, especially with looking at these geographic atrophy events. Ocular hypertension occurred in some patients, possibly related to the volume. We saw a low rate of vasculitis, which we'll dive into, and about a 5% rate of new onset wet macular degeneration. When we dive into the patients who developed vasculitis, most of them had non-occlusive vasculitis. There was one patient with occlusive vasculitis. This was mostly after the first pegcetacoplan dose, similar to what we'd expect based on all that we know about the adverse event of inflammation. And we saw most of these patients recovering vision. The one patient with occlusive vasculitis did fall down to no light perception, which is also what we could expect from a severe case of intraocular inflammation. And that, of course, is the case that we fear. In summary, this analysis showed a rate of IOI of 0.1% per injection, less than the overall rate we saw in the Gale study. Conversion to wet AMD was similar to what we saw in the Gale study at about 5%. This is the first description of outcomes in patients with neovascular macular degeneration receiving pegcetacoplan for GA, and the mean number and treatment of anti-VEGF injections remained stable before and after pegcetacoplan. Dosing was usually between 1 and 2 months, with very few patients being treated at very far extensions. I appreciate your attention, and we're on to the next presentation.
Thank you, David. Next, we have Theodore Lang discussing IRIS registry analysis of anti-VEGF treatment intervals in patients with concurrent NAMD and GA.
I'd like to thank the conference organizers for this invitation to present to you today. Let's see here. Great. Can we have it? So advanced macular degeneration can present as either geographic atrophy or neovascular AMD, but both can occur simultaneously in the same eye. So if GA appears first, it may impact the effectiveness of anti-VEGF therapies. The purpose of this study was to characterize the clinical features and anti-VEGF treatment outcomes in patients diagnosed with coexisting GA and neovascular AMD. We aim to characterize the demographics, clinical characteristics, anti-VEGF treatment patterns, visual acuity outcomes, and key adverse events in eyes with both GA and neovascular AMD. To do this, we looked at the American Academy of Ophthalmology's IRIS registry, which has been previously described multiple times in this event. The study period here was from 2016 to 2022, and eyes were indexed on the date of their first anti-VEGF injection with a 6-month look-back period. They had to have at least 12 months of follow-up study data to be included in the study. Note, this study period was before the availability of the 2 commercial GA treatments that are now on the market. So no eyes in this study received any complement inhibitor therapy. We started with a pool of about 430,000 eyes, and after applying our ICD-10 code criteria and excluding those without age or sex data, we ended up with 26,838 eyes. We also limited data to those eyes that had an anti-VEGF injection in the same eye within 36 months following GA diagnosis, and to patients who had at least one visual acuity measurement prior to the first injection. We then took those 26,838 eyes and divided up into 3 cohorts. The first cohort were eyes that had a diagnosis of neovascular AMD first before geographic atrophy. The second cohort had GA before neovascular AMD, and the third cohort had diagnosis concomitantly at the same time. Note that these did not represent the date they developed GA or neovascular AMD, but rather the date that they were first coded in the registry. So across all cohorts, we found the mean follow-up time was about 2.5 years. On the right side of this slide is a graphical presentation of each of the cohorts again, so that we can have a better understanding. The top one is the first cohort, where the anti-VEGF injection was given at the time of GA diagnosis, and that's our index date. The cohort 2, then the one below that, anti-VEGF injection was accompanied by the diagnosis of neovascular AMD on the index date. And in cohort 3, the index date was the date of the first injection. The time between these 2 diagnoses is also represented in the table on the left. In cohort 3, you can see that they were all given the injection at the same time, so they're all within the 14-day period. With regards to baseline demographics, GA patients with concomitant neovascular AMD tend to be older, greater than 80 years, majority female, majority Caucasian, and non-Hispanic. These characteristics were generally similar across all cohorts. The baseline comorbidities were also similar across all cohorts, with 30% of eyes having cataracts and 90% of those eyes were being treated by a retina specialist. A previous publication in Ophthalmology Science by our group only looked at eyes with GA baseline and did not have AMD, neovascular AMD. And when compared with the current analyses here, a coincident diagnosis of neovascular AMD and GA at baseline resulted in worse visual acuity than those with neovascular AMD diagnosis before GA or those with GA diagnosis before neovascular AMD. This slide depicts the change in visual acuity from baseline through each year of treatment. The orange line shows 0 letters of change. After 6 years of follow-up, the mean visual acuity dropped by 9, 5, and 9 letters for all of the 3 cohorts. Loss of vision in neovascular AMD over time has been previously reported. However, when looking at median vision loss, it happens more slowly when neovascular AMD appears after geographic atrophy. Half of the observed patients with GA prior to neovascular AMD had sustained or improved vision from baseline through treatment year 3. Visual acuity declines were consistent across cohorts in the treatment years 4 through 6. All agents on the market during the study period were considered. The port delivery system and brolucizumab were not shown here due to low numbers and were excluded from further analyses. Basically, we found that half of eyes were on bevacizumab and the others were split 50-50 between aflibercept and ranibizumab. Consistent with patients who are new to anti-VEGF treatment, those with GA before neovascular AMD were more likely to have had bevacizumab as their index agent. Since survey data has shown that half of all ophthalmologists prescribe this agent. For those with neovascular AMD before GA, the proportion of bevacizumab is lower since those eyes may have been on bevacizumab prior to the index date and then potentially switch to a different agent. In the analysis of treatment patterns, we looked at the length of anti-VEGF treatment in all the cohorts. Most eyes had more than 2 years of treatment. There were differences in discontinuation in the first year between the 3 cohorts, as you can see here. It ranged between 11.2 and 16.9%. This may suggest earlier stopping due to a more guarded visual prognosis with GA, as reflected by earlier stopping with concomitant diagnoses, and even more when GA existed longer. We also looked at the interval of injections after the index. Here, the different colors represent different interval of time. The mean anti-VEGF treatment intervals for all cohorts were similar, between 7.5 and 8.5 weeks. You can see here that the most common interval was about 7 to 10 weeks, which is consistent with prior real-world analyses. For eyes with GA after neovascular AMD, they had more frequent injections during the pre-index period. After the index date, the proportion of those between 10 to 17 weeks increases, which makes sense since more time has passed and eyes have potentially been extended. In eyes with GA before AMD, we found a smaller proportion of eyes in the 10 to 17 week interval. This could be due to less follow-up time for this cohort, more discontinuation, or possibly more aggressive lesions. Regarding adverse events, we only counted the first one of each kind and included a washout period of 6 months. The most common AEs were glaucoma and elevated IOP, followed by intraocular inflammation. We did not find any difference between the cohorts except a slightly higher rate of glaucoma developing for the cohort with neovascular AMD first. Looking specifically at intraocular inflammation, the rates of any IOI were highest for those with diagnosis of neovascular AMD prior to diagnosis of GA, specifically for endophthalmitis and iridocyclitis. Rates of retinal vascular occlusion were highest for those with GA prior to neovascular AMD. Our study had some limitations. First, the treatment pattern variation between cohorts may have been minimized by including the first year of treatment in the analysis. And while over 70% of ophthalmology was represented here, there still could be some variation between patients in the registries and those that were not. Since the study runs through 2022, any changes in the management of GA or neovascular AMD that since that time may not be reflected in the data, including the approval of the anti-complement therapies. In some cases, both patient eyes were included in the analyses, and patients with bilateral disease may be managed differently than those with GA and neovascular AMD only in one eye. In conclusion, this retrospective cohort study used the registry to look at patients with concomitant GA and neovascular AMD. Not surprisingly, coincident diagnoses led to worse baseline VA. About a third of this group had vision of 2200 or worse. Through year 3 of treatment, visual acuity declines of at least 15 letters lost were observed in 25% or more of coincident GA and neovascular AMD patients. Half of observed eyes with GA prior to neovascular AMD sustained or improved visual acuity through treatment year 3 after a VEGF therapy was initiated. Across all cohorts, bevacizumab was the most often used initial anti-VEGF. About half of the eyes studied in the analyses had more than 2 years between the first and last injection. The highest level of injection discontinuation was in year 1 for those with GA before neovascular AMD. And on average, patient diagnosed with GA before neovascular AMD had a shorter anti-VEGF interval compared to other cohorts. The most common adverse events included glaucoma, elevated intraocular pressure, retinal vascular occlusion, and endophthalmitis. Thank you so much for this opportunity.
Great. Thank you, Dr. Lang. Next, we have Samuel Miniker discussing retrospective real-world use of pegcetacoplan, practice patterns, and adverse events.
Thank you for the opportunity to present this paper as well as to our collaborators at Wills. Here are my disclosures. Sorry about these slides. They didn't look like this when I submitted them, but pegcetacoplan was the first FDA-approved therapy for geographic atrophy. Initial concerns after the REST report for intraocular inflammation and retinal vasculitis led us to want to look at real-world adverse events. And given that practice patterns can differ from clinical trials, we also wanted to look at practice patterns as well. And so our review used 2 EMR databases, current as of April 1st, 2024, using ICD-10 codes and billing data. We combined the Retina Consultants of America database as well as the Mid-Atlantic Retina database, and this comprises over 2 million annual patient visits. Here is the vials of pegcetacoplan in blue and avastin captad pegol in green, used monthly across all RCA practices. You can see an initial flattening of the use of pegcetacoplan after the initial REST report. And then subsequently, there's been increased use of both medications. In terms of the demographics of patients taking pegcetacoplan, there's 6,500 patients, 8,900 total eyes, 32,000 pegcetacoplan injections, with a mean age of 82.7 years. 2/3 of the patients were female, with a baseline median visual acuity of 20/50. About 21% of the eyes were receiving anti-VEGF at baseline, with an average treatment interval of 45 days. 21% of patients received at least one same-day bilateral injection, and there was an increase in the proportion of patients receiving bilateral injections after each subsequent injection. We looked at best recorded mean visual acuity over the initial 8 injections because the numbers started to fall off after that, and it appeared relatively stable with sort of when you pooled both groups, patients with geographic atrophy and patients with neovascular AMD with atrophy. We then subdivided this based on initial visual acuity, with patients in blue 20/50 or better, and then in orange 20/60 to 20/150, and then yellow 2200 or worse over the first 8 injections, and it appeared stable over that time period. When we separated this to geographic atrophy only at baseline, it appeared very stable for this group. But there was a slight trend in patients with wet macular degeneration and atrophy to worsen over those 8 injections, although this was not statistically significant. We looked at intraocular pressure, it was very stable over the first 12 injections, and our patients had a mean baseline cup to disc of 0.3. In terms of adverse events, about 4.2% of eyes developed new choroidal neovascularization, 29 eyes developed mild IOI, mainly intermediate uveitis that resolved with topical drops. There were 4 cases of occlusive retinal vasculitis, all post first injection, and then 4 cases of infectious endophthalmitis, 2 patients with vitreous opacities, 2 patients with retinal detachment, and there were no cases of NAION. In terms of our patients with avastin-capted pegol, there were 851 patients, 1,090 total eyes, 2,500 avastin-captol pegol injections, with a mean age of 82.2. 70% of patients were female, with a baseline median visual acuity of 20/60, and 21% of these eyes had anti-VEGF at baseline. The average treatment interval was 53 days. 25% of these eyes had previously received at least one pegcetacoplan injection, with 9 of these patients eventually being switched back. In terms of adverse events, 3.3% rate of new CNV, 1 case of mild IOI. There was no cases of occlusive retinal vasculitis, endophthalmitis, vitreous opacities, or NAION. This is a large database combining practices across the United States in terms of our strengths, but there are limitations to retrospective data from EMR-based data. And so in summary, this is a very large data set when we collaborate with Mid-Atlantic Retina. The use of these medications have increased across both practices since the initial REST report, a 4.2 and 3.3% risk of CNV over the time period of the study, a 0.5% and 0.09% risk of mild IOI, and a 1 in 1,630 risk of occlusive retinal vasculitis after pegcetacoplan, just first injection, based on our data set, although in the real world from Apellis, it appears that that's closer to 1 in 4,000, and there were no cases of avastin-capted pegol. We're currently looking at this database, and in particular, the patients with neovascular AMD and atrophy. Ed Wood and Austin Retina is going to be looking at this cohort, and we're hoping to have imaging data on all those patients as well at around Q1 of 2025. I'd like to thank you all for your attention. Thank you.
Great, thank you. If we could have our speakers come back, I'd love to open up for questions. David, when you pop back in, you did answer a question in the chat, but I'm going to pose it to you here so that everyone can have the benefit of the answer. The question was, do we know what % of patients had a concurrent AC tap at the time of pegcetacoplan injection?
Yeah, that would be great data to have because it is certainly something that we see in the 100 microliter volume injections that it's not really dangerous to the patients, it seems. We would have had a signal in the registration trials for either ACP or pegcetacoplan, I don't think, but it's frightening to them when they have a blackout or a whiteout with the volume, even if it's just for a couple of minutes. So I do personally perform anterior chamber taps in a greater proportion of those patients. I think less than 10% still, but of course, that's much more than the less than 1% I perform AC taps in for 50 microliter injections. That would be a cool real world analysis. Maybe for next year's iVista meeting, we can look at a database and see concurrent AC taps coded on the same day as injections associated with GA, even though I don't think everyone puts that injection into their coding when they do it.
Very good. And not to pick on you, but I did have a follow-up question.
Sure,
It
yeah,
looks like
of course. Pick away.
A lot of the data favors the monthly injection for pegcetacoplan. How do you have that discussion with your patients with weighing having to come in every month versus, the possibility that you still get benefit with every other month treatment?
Yeah, so, I think that patients fatigue of these injections even more than they fatigue of injections for exudative disease because there's no measurable improvement at any point in their course. You can't reflect back on a period of improvement. It's difficult to encourage them. So what I typically do when I'm starting patients on GA treatment with either ACP or pegcetacoplan, I start them out monthly so I have a fallback position because most of them do fall back. If I feel that if I start them out every 4 to 6 weeks, and then they fatigue, I can back them off to 6 or 8 weeks and still have an evidence-based benefit. But if you start them out at every 6 or 8 weeks or every 2 months and then they fatigue, you really got nowhere to go with any modicum of evidence to help.
Very good. Very good. Ted, now it seems that we're entering a world where, we're treating neovascular AMD very well, and a lot of your data suggests that the GA component seems to be the more damaging component. When I learned retina and ophthalmology, it was always wet AMD was the most feared complication of AMD. Do you think we're getting closer to a point, although we have some treatments now for anti-complement factor, are we entering a point where GA is potentially more feared?
Well, I think that's an interesting paradigm shift in the way we're thinking about these eyes. I think we've seen great success and efficacy with our anti-VEGF treatments. And so a lot of those eyes are being returned to their native dry state prior to developing the neovascularization. And so I think it's uncovering more of the underlying smoldering disease that's happening with the dry form of macular degeneration. So a lot of attention now is being turned toward that. And I think that for a good thing for our patients.
Very good. There is a question in the data set, or excuse me, the Q&A here. It's not to anyone specific, but if anyone is aware of evaluating the effect of non-invasive subthreshold diode micropulse laser for GA using real-world data. Has anyone have any experience with that they could share?
Well, we've got the new Lumathera data to look at as that laser rolls out, but I have no existing real-world data.
Yeah. I don't either. I thought I'd open to the group though. All right. So Maida, with regards to use to PDT, how do you work it into your clinical practice for treating patients that are already getting injections? Do you wait in certain people that aren't able to extend? Do you use it? Do you use it early? How do you work it into your clinical practice?
What I didn't say when I was giving a talk is that we excluded polypoidal choroidal vasculopathy because we know that PDT works beautifully on the PCV. So those patients were not included in either of those studies. I do exactly what you said. I treat them if I cannot extend them with a good morphology and preserving their vision, then actually we discuss PDT. Frequently, you don't have good targets. I always do FA and ICG more so than the FA to see the feeder vessel because I'm aiming everything at the feeder. If I don't have good targets, then we go back to square one and we inject. And now we have actually medications that are much better durability. So this was actually done while we were not injecting with aflibercept high dose nor faricimab. But yes, that's what I do. I treat them if they have persistent disease activity, if I have the fluid, if I see that the fluid is getting more robust, if I see that fibrovascular tissue is getting bigger, regardless on the maximum treatment, then actually we discuss PDT. I do it quite a bit. I actually do at least 6 patients a month for the PDT for different reasons, and maybe 30 to 40% of those patients are the patients with neovascular AMD that is not polypoidal choroidal vasculopathy. Those are usually elderly. Those are patients who don't have good family support to come to frequent injections, patients who experience fatigue from the injection, what David was talking about. So that's actually how I choose that.
Very good. Do you see a potential for using PDT even with the longer acting anti-VEGF agents? Meaning, do you think we could extend it even further than what we already are?
That would be amazing. I think there is a room for both, how I see it. And we just have to carefully choose patients and not forget about the imaging. People are not using ICG anymore. It's sort of coming out of favor. So I think if you do the ICG and you can classify diseases, the disease that can be amendable by the PDT, I think that would be the way to go.
Very good. All right. I'm not seeing any other questions in our chat here. I think to try and get us back on schedule, we're going to move to the next segment. We're going to have a quick talk by one of our sponsors, Genentech. We are grateful for their support. And so there will be a quick video presentation by them. Thank you. Thank you all the speakers.
Thanks for having us.
Faricimab, first bispecific in retinal disease, really inhibiting 2 different pathways. We know that retinal diseases are multimodality, so we wanted to make sure that we are able to bring forward a therapy. It's been a while since we've had something really new come to the market for you, and we're really learning how to use this in an optimized manner. There's been over 95 countries with approval with faricimab, and as far as usage of faricimab, greater than 5 million vials have been distributed. That means there's a lot of patients that have really benefited from faricimab, a lot of learnings from the doctors who've been taking care of patients that have been using faricimab, and continues to be a very favorable risk-benefit profile for this product, which we're extremely happy about. Today, we're going to be talking about, there's all that clinical trial that you saw in the video, but what's important is the data that's coming from doctors such as yourselves. We collect a lot of data in our Voyager program, as well as registries that we analyze, FAR Retina, FAR Y. These are very large databases in the US and the UK that really allows true behavior to be identified in terms of how faricimab is really doing out there in the real world. We're seeing independent studies being published also. And what we want to talk and really kind of test this hypothesis is, in the past, we haven't really seen real-world data match clinical trial data. And with monotherapy anti-VEGF, it was really hard to implement those regimens that were in the clinical trials. But with the trial design in the faricimab study and really the dual inhibition and the new mechanism of action, I think we're really kind of seeing real-world data mirroring clinical trial data really for the first time in almost 20 years since the first launch of some of the early anti-VEGFs. You see here some of the bigger data. On the left side is our clinical trial data of Yosemite and Rhine. And what I just wanted to point to very quickly is that the shape of the curve is the same. This is visual acuity over time. And once again, once you're out in the real world, patients are not in inclusion-exclusion criteria. They're robust set of variations out there, but we're still seeing a very positive trend in the same direction mirroring the clinical trial. And we see it also right here in AMD and Tenaya Lucerne in terms of the CST dropping, once again on the left side with the clinical trial, on the right side with the real-world data. Durability is a big question. It's maturing over time, but what we're seeing here on the left side, Tenaya Lucerne, you see the big red, that's greater than 8 weeks. We're seeing also replication in the real world. There's 2 examples here on the right side at Moorfields and also in Liverpool too. So once again, it's mirroring. It's still early days, but things are mirroring in the right direction. With that, we hope to turn that unequal sign to an equal sign, but the data is going to be in your hands to see how this happens.
Great. Thank you. It is my distinct honor and pleasure to introduce our keynote speaker. Dr. Michael Chang is the director of the National Eye Institute of the National Institutes of Health. Prior to becoming director and even throughout his time, he has been a powerhouse researcher in the areas of artificial intelligence, retinopathy of prematurity, biomedical informatics. He has over 350 publications, nearly 25,000 citations of his work. He has been a tremendous champion for the use of real-world data and cooperative data science. So again, it's my honor to introduce Michael Chang.
Brian, thank you very much for that introduction. It's great to see you and to just be here today. What I'm going to be doing is just talking about real-world data and just sharing some perspectives from the National Eye Institute. I'm going to wait for this to advance. What are we? We're the branch, as Brian mentioned, of the National Institutes of Health that manages national efforts in vision science. Okay, so what we do is we direct vision research and we fund vision research. And our budget this year is $896 million. And that makes us the biggest funder of vision research anywhere in the world. Now, what I can talk about here is so much less in 15 minutes than what we're doing in Bethesda and at NIH. And so, please sort of consider following us on social media. I've been trying to use this to disseminate information that may be of interest to the community. The Twitter handle is NEI Director. And on LinkedIn, it's Chang MF. Okay. So what I really want to do is talk about 3 things that I think are going to be relevant to real-world data as I see it. And number 1 is that clinical discrepancy. So here are some data that Pete Campbell and Jeshua Kalpathy-Kramer published. And this happens to be data from ROP, but I think it's true for any area of ophthalmology and probably any area of medicine. So this happens to be 8 experts on the left side looking at 100 different images. Okay, so each column is an image, each row is an expert. And the expert is asked to diagnose something. Look at an image, diagnose it severe, moderate, or normal. Okay, if that box is severe, if that expert diagnosed that image severe, the box is in red. If they diagnose it as moderate, it's in yellow. And if they diagnose it as normal, the box is in green. Okay, and so this happens to be plus, pre, plus, or normal. Okay, but anyway, experts number 7 and 8 down at the bottom diagnose severe 6 times more often than expert number 1. Okay, and we see this, and you go to a different data set at the bottom, database B, it's the exact 6-to-1 ratio. Okay, so we have overcallers and undercallers. And the point that I want to make from this is that each of these 8 people is a world expert. We can't agree on the diagnosis. And the challenge here is, what is the ground truth? When you get data sets and they give a diagnosis, if you were to ask someone else to do that, there are major differences in clinical ascertainment. Okay, and how do you establish ground truth? There's a lot of different approaches. Okay, so that's challenge number 1, point that I want to make. There are clinical discrepancies. It's not so easy to use real world data because of that. Okay, so point number 2 I want to make is the growing role of imaging and AI in research and just in clinical care. Okay, so this tweet on the left is from Eric Topol in 2019. Of all the medical specialties, most people think radiology is leading the AI movement, but it's actually ophthalmology. Okay, and there's many reasons for that. A lot of images coupled with clinical outcome data. Okay, there really aren't that many fields that can do that. And all of you know that the first FDA-approved AI for autonomous use in any area of medicine was for diabetic retinopathy, right? Michael Abramoff at the University of Iowa. Now, this slide on the picture on the right here shows data from this past year. These are number of FDA-approved AI systems by field of medicine, and radiology is number 1 in orange by a really large margin. Okay, so in ophthalmology, we're down at number 6 right now. And so one of the challenges is, how are we going to better translate real-world data into research, into real-world systems? And I think that's a challenge that we're all going to have to deal with. Okay. So the point of this slide is, if AI is so good, why do ophthalmologists have jobs in 2024? There are many reasons for that, obviously, but this slide, I want to show some data involving challenges of generalizability in AI. Okay, now this happens to be data that Jimmy Chen and Aaron Coyner from Oregon worked on a couple years ago. And so this is an AI system for retinopathy of prematurity. And you have to train a model and you test a model. Now, if you train that model on babies from North America and test it on babies from North America, the system works really, really well. Okay, the first row. If you train it on babies from Nepal and test it on babies from North America, the performance drops off really dramatically. Okay, but if you build a large data set of babies from North America plus Nepal, and then you test it on babies from North America or from babies from Nepal, it works really well again. Okay, so the point of this is that the real world is heterogeneous. Okay? There are many different imaging devices, different races, different populations, and you cannot take findings from one group and just extrapolate it to another group. Okay, and to build generalizable AI systems, we need to use large, diverse, multi-center data sets. Okay, really, really important. And that's shaped a lot of the stuff that we're doing at the National Eye Institute, because we really need to build systems that are useful for the entire population. Okay, so with that said, one of the things we need is larger data sets to avoid the kind of bias that we had on the previous slide, North America plus Nepal. So there's an NIH Common Fund project called Bridge to AI that I want to make sure you're aware of. So Common Fund, what that is an NIH program, any area of medicine, any area of science. Okay, these are really, really big projects. So Bridge to AI phase 1 is $130 million over 4 years. And the goal of this is to generate diverse, large flagship data sets across multiple disciplines to use for knowledge discovery. Okay, so this is basically a hypothesis generating project, $130 million. Okay, really, really, different direction for NIH that we're taking. So a few years ago, there were 4 projects that were funded using this $130 million. And I was really excited that one of them was led by a team of ophthalmologists, Aaron Lee and Cecilia Lee at the University of Washington. And they're going to be talking later here today. And so I'm just going to leave it to say that, we're really interested in building larger data sets to avoid bias. And this is an exciting project you'll hear more about. The third point that I want to make is how important it is to have data sharing and data harmonization for real world data. Okay, the reality is that most people do not have $100 million to build flagship data sets, and modern research relies on data sharing and harmonization. Okay, we see this all the time, where the first bullet point here is that there are multiple small studies going on in parallel around the country or around the world that are basically trying to answer the same question, yet are individually underpowered to really be able to do that. And so we don't advance the field. Okay, and one of the challenges is that individual people are not incentivized to share data with each other. Okay, in fact, the academic system, in many ways, disincentivizes people, to share. I'll talk a little bit more about that. The other reality is that even if people did want to share, if you represent your data and collect it inconsistently, you can't combine those data sets anyway. Okay, so we need data harmonization as well. Okay, so I'll talk a little bit more about that. Now, in terms of data sharing, at the NIH and at the White House, we have data sharing policies. Okay, if you don't come up with a plan to share your data, we won't fund your research. And I know that's controversial and frustrating within the community. And I really firmly believe that in addition to those so-called sticks, we need incentives for data sharing to make people want to do it, carrots, if you will, to go with those sticks. And for the past few years, in terms of those carrots, I've been meeting with the editors-in-chief of the major vision journals a few times a year. What can we do together to advance the field? And a few years ago, we came up with this idea, well, let's create a new publication type called a data set or software library publication type. So you can write a paper just to publish your data. And the rationale with that is that people could get academic credit for publishing data. Somebody else could cite it if they use it, that you can find it using PubMed. And Marco Zarbin was the editor-in-chief of TVST at the time. He and Pierce Keen and Aaron Lee wrote up an editorial to define this new publication type, a vision data set or software library. And I think it's going to be things like that that we need to do to gradually shift the culture toward incentivizing data sharing and incentivizing team science. Okay, so that's how we do things in the 21st century. Now, along those lines, we've been having a lot of conversation about this in Bethesda. And we've recently, about a month ago, announced what we're calling an NIH S-Index Challenge. Okay, so this is a $1 million challenge to develop a metric that measures how well somebody shares data and how useful that data is to other people. Okay, and so there's 17 groups at NIH that are involved with this, and we're the lead. And really excited about this because, again, in the spirit of creating incentives for collaboration and data sharing, I think we need to shift that culture. Okay, so it would be great to be able to develop this metric, get it into Google Scholar, get universities to care about it, and so on. Okay, so stay tuned about this. In terms of sharing data and collaborating, there are two approaches. Number one is to centralize the data. Everybody around the country sends data to a central hub. Okay, and there are many different models of this. The American Academy of Ophthalmology's IRIS registry. Okay, at the University of Michigan, there's a source consortium that Josh Stein runs. And many benefits of this. It's very logical that data get analyzed and accessed through this single hub in the center. Okay, a lot of disadvantages, though. Okay, for example, you need data use agreements if you're going to send clinical data from one site to another, and those can be really, really cumbersome. Okay, they can take years to set up. And the other thing is that if you're sending really, really big imaging files or systemic data from one site to another, it's not always practical to do that because those files are so large. Okay, so there are disadvantages of this centralized model as well for dealing with real world data. Now, an alternative model that we've gotten really interested in over the past couple of years is federated data networks. And I know Michelle Rybar and Cindy Kai are going to talk more about this. And so let me just give a brief overview. Okay, the way these work is that the data do not get sent from site to site, but you analyze the data in parallel and you share the analysis methodologies and results. Okay, and there are a lot of different examples, what I'd call sort of proof of concept examples of these federated data networks that you'll hear more from. But the benefit here is that because you're not sending data from site to site, you don't need these data use agreements, and you can deal with large files and scale this much more easily. Now, the con, though, of these federated networks is that because you're not sending data back and forth and analyzing in parallel, it's really, really critical to make sure the data are harmonized. Okay, and that's what I want to talk about here, interoperability and common data models. Okay, the reality is that electronic health records are not harmonized. Okay, two epics don't really talk to each other, and that makes it really, really tough to collaborate. Okay, and we've spent about 2+ years at the National Eye Institute working with the AAO and others to try to create this common data model for ophthalmology. Okay, so what these do is they take these in the diagram on the right, all these apples and oranges at different sites, convert them to an integrated data ecosystem in the middle of apples and apples. And then if you do that, you can create standardized cohorts and phenotypes and do that federated data analysis on the previous slide. Okay, and I think it would be an amazing vision if the ophthalmology community could standardize data and integrate into this sort of multimodal data ecosystem that includes eye data, imaging data, and also systemic data. Okay, now who's leading this? Sally Baxter in San Diego, Carrie Getz at the National Eye Institute, and Michelle Rybar in Oregon, who spent 2 years at NEI on a sabbatical working on this. Now, does this actually work? About a year ago, Cindy Kai, a retina specialist at Hopkins, got supported to do a pilot study. That Cindy's going to talk more about this. But the point that I want to make from this is that in that study, Cindy looked at 12 data sets from around the world, including 485 million patients, and then identified about 6 of them that sort of had the diseases that are relevant to her study, and did this analysis within 9 weeks from beginning to end. Okay, so really, really powerful, and there've been other examples of this that you'll hear about. And so based on this, we've been really excited, and we issued a $1 million NEI challenge to basically propose questions that can be answered using federated networks like this. And if you want to learn more about that, go to this QR code. Okay, so really excited about that. Okay, the last thing that I want to talk about is ocular imaging standards. Data come from these imaging devices. And the problem is that you can't get access to raw data in general from those devices because they're locked in proprietary standards. Okay, that's a huge barrier to clinical care and to research. And this has been going on for 20 years in the vision field, and it really hasn't advanced. And the radiologists have solved this decades ago through the DICOM standard, where all these devices are plug and play. But we're struggling with this still. And when I started this job, I really felt like we have to change that. And so, we got together with the FDA because they regulate imaging devices, and with the ONC, the Office of the National Coordinator for Health IT, because they regulate data exchange. And what can we do to advance this? And we held a workshop. The AAO and ARVO put out a position paper endorsing that we really need to develop these levers to promote interoperability. And we put out a position paper earlier this year that describes what those levers are. And basically, I don't want to be funding grants moving forward if they use devices that don't adhere to standards like DICOM. Okay, that's how we're going to do the best research and how we're going to take the best care of patients. So my last slide here, the key points are there are a lot of limitations of clinical data. Okay, the O in SOAP is not truly objective. And we got to deal with that. There's a lot of opportunities in our field because of things like imaging. We talked about AI, need to build large, diverse data sets to create generalizable systems, and a lot of approaches that we're working on. Data sharing, collaboration, federated networks, interoperability standards, and common data models. Thank you very much.
Dr. Chang, thank you. Thank you for taking the time. We have a few minutes for questions. If anyone would like to offer a question to Dr. Chang, while we wait for a question to come in, I do have a question for you. I agree that the federated data systems seem to work best simply having spent 2 years at Penn trying to get data into source, just working through the data use agreements. They're very onerous. The flip side, as you said, is that you're going to have more resources at the local institution. How do you incentivize that? How do you get people to move in that direction to potentially broaden the network, but still keep people involved?
Yeah, Brian, great question. And I think there are a number of major systems around the country that are doing this on their own, just because they want to be able to share data and stand. University of California is a big, there's a UC-wide repository that's all based on the same common data model that we're using. That said, I realize it's a challenge. We talked about this $1 million Odyssey network challenge. And the way that we're trying to deal with it is that, if it takes you an engineer to get your data converted to this common format, the goal of this is that you propose a study, and if we sort of select the study, then you get $200,000 to hire that engineer to do the work. And so that's how we're doing it, to try to get over that hump. And I really hope that if people see the benefits of that, that they'll want to be able to do that on their own. But really important issue.
Very good. Well, thank you again for the time. We really appreciate you coming to speak with us today. We will move on to the next session. My co-organizer, Durga Borkar, will be taking over from here. Thank you.
Great. Thanks, Brian. And thanks to Dr. Michael Chang for a great keynote talk. We'll be kicking off session 3 now, which is the applied methods section. We'll actually be hearing from many of the data scientists that he discussed during his talk. Our first talk will be from Dr. Aaron Lee from the University of Washington, who will be talking to us about Bridge to AI. Welcome, Aaron.
Thanks so much. If I could pick one person to steal my thunder, it would be Michael Chang. So I'm glad that he had the opportunity to kind of give an overview before we dive a little bit deeper into the topics. So I'm going to be talking about Bridge to AI, and I want to give a little bit of a background. These are my financial disclosures. So the Bridge to AI program is a NIH-wide common fund program, and it's really focused on the very first, half circle that you see on the left side of this slide. It's really about data preparation. And so the Bridge to AI program really is, in my opinion, a bridge to AI. So there's very little AI work that's actually happening inside of the Bridge to AI program, but it's really about doing some of the really difficult work in collecting standardized data, harmonizing it together, and packaging it for release so that other people and the wider community can do model development. The remit of our data generation project, out of one of the 4 data generation projects in the Bridge AI program, is to generate a multi-dimensional ethically sourced data set in diverse people for studying a process known as salutogenesis in a model disease, type 2 diabetes. So salutogenesis, you may not be that familiar with. You can think of it as the opposite of pathogenesis. So how does the body return back to a healthy state? And our study design has 3 recruitment sites across the United States. The goal is to collect about 4,000 participants, and we really want them to the data set to exhibit this sort of 3 levels of balancing. We want equal distribution across 4 races and ethnicities. So about 1,000 of the people will be Black, 1,000 Hispanic, 1,000 Asian American, and 1,000 white. Equal distribution across different health states. So 1,000 people will be non-diabetic, 1,000 will be lifestyle controlled, 1,000 will be insulin dependent, and 1,000 will be medication controlled. And then 1-to-1 balancing of males and females. And the idea here is that if you train a model across using the sum total of this data set, it'll hopefully be robust and generalizable to these other populations. What are we actually asking people to do in this study, the 4,000 people? So each one of them, we've asked them to fill out a whole bunch of different surveys at home before they come in. When they come on site, we do a whole different battery of tests, including going over their list of medications, doing different levels of vision screening. We do many different forms of retinal imaging. Actually, there's 44 different protocols spanning like 10 different devices. And one of the things we tried to do here is solve the problem of having device dependency in AI models. So we've collected data set where every one of these people are getting both of their eyes scanned on like 5 different OCT machines, and we're releasing all that data. We collect a whole bunch of different blood tests and urine markers. We collect a 12-lead EKG. We do cognitive function testing, and then we bank all their blood at UAB. Now, one of the parts of the protocol that's really interesting is that we also collect data at home. So we ask them to wear a continuous glucose monitoring device, a fitness tracker, and then we have a custom-built environmental sensor that measures different things like pollution levels inside of people's homes. So this is the release of our year 2 data. This was released last Friday. So earlier this year, we released our pilot data that had only about 200 some participants. But now we're up to 1,000, and we released this data set last Friday. It's actually about 2 terabytes of data that you can download to your computers to do research. I want to highlight a couple things. So this is an example of the continuous glucose monitoring device. You can look at different sectors of diabetes and easily sort of see the time that they spend in tight range of glucose be wildly different across these different strata of diabetes. Not only that, if you plot their sort of individual trajectories, you can see the variance increasing and increasing as you go across these severity levels. So we're clearly capturing something very relevant about type 2 diabetes. The other thing I want to just really quickly touch on is the environmental sensor. And this is a custom-built environmental sensor from our lab. It looks like this on the left-hand side, and it collects data both about the spectrum of light that's present inside of people's homes, as well as the pollution levels. And so it measures things like PM 2.5, the volatile organic compounds and nitric oxides. And the idea here is that if we understand, the air that people are breathing, maybe that's more tightly correlated than some of the environmental research that has been done so far in medicine, which is usually zip code based. And so here, what we were very excited to see is that if you look at the maximum level of particulate matter in people's homes, there's sort of a dose-dependent effect that you can see with the type 2 diabetes status. And this we just discovered just by cleaning our data. So we were just making sure the data looks okay and looks reasonable. We ran some first-level things to look at the distributions, and this sort of caught our eye. So this is very exciting stuff. There's no shortage of things, in my opinion, that could be discovered using this data set. And we're hopeful that many of you who are listening on this call will be able to kind of download this data set and use it. So how do you actually access our data set? We have these different platforms. The data is actually hosted on the platform that we've created called fairhub.io. But if you want to read about our data set, go to aiready.org. It'll take you through the whole thing, explain all the documentation that we have with this data set. So if I can get my slide to advance. This is a massive project, right? So there's a lot of people who are involved in this. I think there's like 150 people that is supported by this grant. I'm indebted to all the PIs that are listed on here for their really hard work to make this happen. So thank you very much. And I guess I'll end there.
Great. Thank you so much, Aaron. Next, we'll have Dr. Brian Vanderbeek speaking on the magic of propensity scores.
All right. Thank you, Durga. Good morning again, everyone. With the increasing use of propensity scores more and more in the ophthalmic literature, I thought it'd be helpful to kind of give a general overview of what propensity scores are. This is probably a topic that should have 2 or 3 hours devoted to it. So of course, I'm going to do it in about 6 minutes. All right. So just a general definition. Once the slides progress, there we go. A general definition of a propensity score. Quite simply, it's the propensity or probability of being given a specific treatment based on observed variables. Using propensity scores tends to balance observed covariates between comparison cohorts, which is the goal, to try and get as an apples to apples comparison as you can in any real world study. So how do you do it? just the general nuts and bolts of creating a propensity score. You're going to use a logistic regression model and include all of the covariates of interest that you want into the model that might predict the use of a specific treatment, not necessarily the outcome, although you want to include variables that would be related to the outcome as well. The outcome of the model is the propensity of a patient to receive that treatment, and the results are going to vary from 0 to 1. 0% chance a person was given the study treatment to a 100% chance to the patient was given a study treatment. And really importantly, there is no limit on the number of variables you can use in a propensity score model. After you create your model, it's helpful to do a diagnostic diagram of what the two cohorts look like based on the propensity scores. In a perfect world, you'll have a situation most like C, where there's very little treatment preference between the two, and there's a lot of overlapping propensity scores, which will make it the best for comparison. Most often in the real world, we end up with something in figure B, where there's a lot of overlap, but not complete overlap. And then, unfortunately, if you have something in A, you probably either shouldn't be running the study because it's just not an apples to apples comparison between your comparison groups, or you need to pick a different comparison group so it's more similar between the two. Here's another diagram from a review article just to kind of show the point. Propensity score of 0 is on the left, and on the right is a propensity score of 1. And you can see that what's going to end up in the actual study is a matched cohort. One of the drawbacks of propensity scores, you do lose sample size. Of course, that's within the context of often using these very large real-world data sets where you have a ton of patients. So in this example, we go from nearly 6,800 patients down to a matched cohort set of around 2,800. Of course, that's going to be a much better analysis in the reduced sample size because they're going to be much similar to each other. There are a lot of different varieties of propensity scores. You can control for it as a covariate. You can stratify based on propensity score, then run the model within each stratification. The most common, as we said, is matching. It's also the most straightforward. There are a lot of variations to matching. You can do it with or without replacement. You can use greedy versus optimal matching. And when you're talking about matching, it's important to discuss caliper size, which is essentially how far apart the matches can be and still be considered matched. Also, you can use inverse probability of treatment weighting. This is helpful when a pre-calculation of a propensity score is not practical, like times when you have to assign an index date to a control population. The cutting edge of propensity score modeling, and I haven't seen this used yet in ophthalmology, I may be wrong on that, is high dimensional propensity scores. These are AI-based and often use tens of thousands of variables to create the propensity score. So I thought I would go over an example, and why not use the preeminent example that kind of brought propensity scores to the fore, and how they entered into the world of epidemiology and real-world data. Numerous randomized controlled trials demonstrated that aspirin cuts the risk of fatal heart attacks by 50%. However, whenever an observational data study was run looking at this, the aspirin group always appeared to be associated with more MIs. And when you think about it, this makes sense because the people that were getting the aspirin are the ones at higher risk for MIs to begin with. So then this study came along, published in JAMA in 2001, which aimed to show the difference in the benefit of the propensity score here. And the big thing to note is twofold. First, the aspirin cohort had to start it off with 2,310 people versus the no aspirin cohort, 3,864. And when you look at the p-values of the differences between the cohorts at the beginning, all of them were significant. Up and down the board, every single one showed a significant difference, with aspirin typically being the sicker group, which is what you would expect. However, after matching, you do lose some of the sample size, but then also in the p-value, it becomes much more balanced. There's no longer any difference between any of the baseline characteristics. You can also tell how old this study is because we no longer use p-values. We use standard mean deviations to determine how balanced a cohort is. And once you have a well-matched cohort between propensity scores, you don't even have to adjust for anything. And in this study, the hazard ratio matched the real-world data, or excuse me, the randomized clinical trial data showing a 50% reduction in hazard ratio. So this is a study, it's a little busy and it's a lot to digest, so I'll just kind of go over it quickly. And basically just tells you, depending on what type of study you're running and what your question of interest is, should kind of direct which propensity score you want to use. The big distinction between being average treatment effect of the treated versus average treatment effect of everyone, and it flows from there. So in conclusion, propensity scores can reduce imbalance in known observed covariates. There are numerous ways to use propensity scores, and you should tailor your approach to the project. Thank you.
Great. Thank you, Brian. Next, we'll have Dr. Devinder Chauhan speaking to us about real-world clinical outcomes and applied machine learning for quantitative fluid volumetrics of eyes switched to faricimab for neovascular AMD. Thank you.
Hi, thank you very much. Thanks for the invitation. My name is Devinder Chauhan. I'm a retina specialist in Melbourne in Australia, and also the founder of MacuJect, the software that was used to do these analyses. We did this work in Australia, but in collaboration with Professor Sada's group in Los Angeles. It is working. Yeah, a question that we were asking was, does switching patients to faricimab for the control of neovascular AMD actually improve fluid control? So we looked at a group of patients in Australia. It's a real-world study using retrospective electronic health record data and retrospective OCT scans. This is done in 5 clinics with 8 retina specialists in 3 states. Each of the retina specialists said self-identified as performing their treatments with treat and extend, and none of them, they all said they did not tolerate fluid. The patients were all treated from at least the 1st of January. This is the period in which we collected data from, and every patient who was switched had at least 2 years of treatment before the switch. And importantly, faricimab became available on January the 1st, 2023. And the machine learning algorithms here are still being validated. So that's an important point. Looking at intraretinal, subretinal fluid volumes, at the validations looking at the DICE scores right now. The results essentially were the group of eyes that were being studied were 3,082 eyes, of which 779 were switched by the clinicians, obviously at their own discretion, to faricimab. We had machine learning for 563 of those, and of those 563, 473, that's 84%, remained on faricimab. That's the study group we're looking at here. And that's a similar percentage to those that weren't, for whom we didn't have machine learning as well. And what we found was that of all of those 473 eyes, 1/4 had fluid at every single clinical visit for the 6 months prior to switch, and nearly half had an increase in fluid volume at some point during that 6 months. And of all of those, and this is the main result of all of those, for the intraretinal fluid, whether it was present on its own or in combination with subretinal fluid, 81% of eyes had a reduction of the intraretinal fluid volume with faricimab. And for subretinal fluid, whether on its own or in combination with SRF, there was an 85% had a reduction in fluid. And when they were both present, both fluid compartments, 93% had a reduction in the fluid volumes, which are very positive results. What we wanted to look at, though, was also the effect on intervals. Now, if we look at intervals only, the interval that followed switch could readily simply be a function of both the fluid control and other factors. So we're interested in the maximum fluid-free interval. That's the maximum interval at which there was 0 fluid on measurements. And what we found was that when you looked at the intraretinal fluid only, and the red columns represent the fluid-free interval, the maximum fluid-free interval prior to switch, and that was a mean of 10 months before switch, and after switch was also a mean of 10 months. There was an increase in interval, a shift to the right with faricimab, looking at intraretinal fluid on its own or in combination. We found a similar thing for both the subretinal fluid on its own or in combination and a combination of the two. So very importantly, you could see that there was a shift to the right, which is what people were hoping for. We applied some stats to that, and essentially what we found is the shifts were not very large. So for intraretinal fluid, and this is with a mean of 10 months post-switch data, we found that for intraretinal fluid it was just under a week, under half a week. For subretinal fluid and intraretinal fluid and SRF together, the increase in interval was modest. It was just under a week on average. So the obvious issue here is that this is a real world study looking at spontaneous treatments that were totally at the free will of the retina specialists. These were obviously hard to treat eyes, given the amount of eyes that had fluid present beforehand and at the time of switch. What we do know, though, is that there was reduction in fluid for more than 80% of eyes, and there was an extension of fluid-free interval, but just under a week. So this is a very prosaic application of machine learning in real world practice. Thank you.
Great talk. Thank you so much. Next, we'll have Dr. Michelle Rybar speaking to us about the importance of a common data model in ophthalmology.
Thank you. I'm Michelle Rybar. I am an associate professor of informatics at the KCI Institute at Oregon Health and Science University, and I'm going to be talking about a common data model in ophthalmology called OMOP. And, as we've heard so much already, there's been a lot of work in AI and biomedicine in ophthalmology, and ophthalmology is, in fact, leading biomedicine at this. And there's a lot of applications of this across ophthalmology, and one in particular that really intrigues a lot of us is this idea of oculomics, not only because of its potential, but because of the data that you need to actually to study this. It's a combination of really high quality imaging data plus, high quality systemic data, structured EHR data. But in order to study this, we have to have large amounts of data. It needs to be high quality. And we think that observational health data really offers the potential to be able to do these studies, not only oculomics, but in other areas of ophthalmology. And as Dr. Michael Chang already showed us in similar slides, is that we do have a lot of observational health data in EHRs, not only across the United States, but across the world, but a lot of it's siloed because the data is not standardized or harmonized between sites. And as we've been talking about a lot is that, one way to overcome this is to pool data into registries where data is sent to a centralized repository. And examples of this are the IRIS registry, the SOURCE consortium. And this is a very successful way of pulling together data and having our researchers be able to access data in one centralized location. But there are some drawbacks to this approach, and we've mentioned before extensive legal and privacy concerns or agreements that have to be signed, but also it can limit scalability. So it can be very difficult to send large amounts of data or even large imaging data to these centralized repositories. So another approach is to keep the data distributed, but instead share the models and the analysis code between sites so that the data can stay local. This avoids those legal and privacy agreements, but also it's a much more scalable approach. And what we're looking at is doing this through what's called the Odyssey Network, that stands for Observational Health Data Sciences and Informatics. And this is built on top of the common data model known as OMOP. This Odyssey network is really vast. It includes almost 5,000 collaborators across the world and represents 83 countries and almost all the continents. And they have been doing this for the last 10 years. OMOP stands for Observable Medical Outcomes Partnership. It was a public-private partnership about over 10 years ago. And it was between the FDA, NIH, some pharmaceutical companies and academia. And the goal of it was to be able to do long-term medical surveillance of medical products using observational health data. And the outcome of this partnership was the OMOP Common Data Model. And this Common Data Model is just really a standardized structure, content, and semantics, meaning conventions for how observational data is stored in a data mart. And this, since then, has been used widely across the globe, as I mentioned, but it's also been used in a lot of the NIH projects, including data generation projects, such as All of Us, N3C, and Bridge to AI. In fact, the AI Ready data set that Aaron was talking about is built on top of that data model. So Odyssey is the open source community that aims to improve health by collaboratively generating evidence for better health decisions and care. It maintains and updates the OMOP Common Data Model right now, but probably more helpfully develops and maintains tools for the appropriate use of this health data. They have all sorts of tools that can help not only with the conversion of data to OMOP, but also for the appropriate use of this, including extensive R libraries that will do high dimensional propensity score matching. And Dr. Cindy Kai will talk about this in the use in a study in ophthalmology. And I'll skip through this. Odyssey supports research and is fair. It's open source, and it really allows for reproducible for studies. And the amount of data that's in OMOP right now, it includes a standard OMOP really includes data that you would find in claims data, plus some basic EHR data, such as vitals, labs, et cetera. We're working on getting ophthalmic data, such as visual acuity, intraocular pressure, and refraction into the common data model. There are a few sites that have actually added IOP. And of course, the Holy Grail is also integrating ophthalmic imaging data. And I'll skip through some of these. We have a lot of challenges, as we've talked about. We have to have data standardized and harmonized with EHR data and imaging, and we are working with that. And to do this, we have formed a work group within the Odyssey community called Eye Care and Vision Research Work Group that now has over 200 members that are coming together to work on this standardization and to actually help use and demonstrate the validity of this approach. And what we really want to do is be able to create an ophthalmic data network within Odyssey where each individual site can contribute to, and according, et cetera, can kind of manage all this and be able to support the Odyssey network studies that Cindy Kai will give you an example of in the next talk, but also will also support federated learning using imaging. And there are lots of use cases of this, but we're really excited about this approach and looking forward to building this distributed network. And also, anyone who is interested in joining our efforts and joining the work group, it is open to everyone. So you can certainly contact me or Cindy or anyone else involved, and we'd be happy to get you started.
Wonderful. Thank you, Michelle. Next, we have Dr. Cindy Kai from Johns Hopkins University speaking to us about conducting an Odyssey network analysis. Thanks, Cindy.
Thanks to the organizers for the opportunity. So now that you've heard from Michelle Rybar about the OMOP Common Data Model, I'm going to show you the science that's possible when you have a common data model and a whole community working towards it. Let me just see. Next slide. So as Michelle mentioned, Odyssey is a global community. Yes, it's a global federated data network, but more importantly, it's a community of individuals with this vision of improving health through observational research. And they're guided by these values of innovation, reproducibility, community, collaboration, openness, and beneficence. And I take the time to mention them because you'll see how these values come up when we do these network studies. And so it's a multidisciplinary community with all focused on working around this OMAP common data model. There are groups within Odyssey that may focus on maintaining the vocabulary that we use, the common data model, produce tools to evaluate data quality, statistical methods, and other software tools. And then there are the clinical folks with the eye care vision research work group that Michelle mentioned, focused on optimizing the OMAP CDM for what we need. And so I'm going to take the rest of the time to talk about a pilot study that we did that both Michelle and Mike Chang mentioned, where we looked at the association between kidney failure and intravitreal anti-VEGF medications. And we did this because we know that intravitreal anti-VEGF medications, or anti-VEGF medications, when given systemically, have known adverse kidney side effects, including acute kidney injury and proteinuria, which are major risk factors for kidney failure or end-stage kidney disease. And we use these medications quite commonly inside the eye to treat a whole host of potentially blinding conditions. But the systemic absorption between these three medications are very different. It's highest with bevacizumab and aflibercept, and the least with ranibizumab, which has led some clinicians to recommend the use of ranibizumab for patients who are at high risk for kidney failure. So the question that we wanted to ask within using the Odyssey community was, is there any evidence for doing that? Is the risk of kidney failure different between patients who use ranibizumab, aflibercept, and bevacizumab? And so I wanted to, because some of the values of the Odyssey community is reproducibility and openness, every step of this network study, as well as all other network studies, are pre-specified, and you only go forward to the next step when you've passed all the pre-specified diagnostics. So for example, in this particular network study, as well as others, we pre-specified all the cohorts and analytics in a study protocol that we published before running any sort of analytics. And we leveraged a lot of the tools that Michelle mentioned that the Odyssey community created, including an open source, publicly available web-based tool called Atlas to identify new users of our 3 monthly intravitreal anti-VEGF medications. And we also use a lot of R packages created in the Hades suite of R packages, which are focused on large-scale analytics built for the OMAP common data model. So we use the cohort method to analyze new users of ranibizumab with propensity score matched new users of these other medications, and Cox proportional hazards model to estimate the risk of kidney failure while in treatment with intravitreal anti-VEGF medications. And because each database runs this analytics, we needed to use a meta-analysis in order to combine every site's hazard ratio estimate into a single network-wide estimate. And just as a comment on some of these Hades packages, you might be thinking to yourself, well, this is all too easy. All the analytics are already there. But keep in mind, these tools were created by giants in the Odyssey community through years of optimizing this science. So these are just some of the publications that went into the creation of this cohort method package that I had just mentioned. So because of all of this infrastructure that exists, we were able to ask the same question across 12 different databases in a matter of 9 weeks. And you can see the schedule here. So we identified 240,000 new users of intravitreal anti-VEGF medications. And in terms of our main study questions, this is a forest plot from the Cox proportional hazards model. And you can see that the meta-analysis hazard ratio suggests that there really is no difference in the risk of kidney failure comparing between our 3 most commonly used intravitreal anti-VEGF medications, meaning as the treating ophthalmologist, I'm free to choose between any of them without worrying too much about differential risk of kidney failure. So hopefully I've shown you the speed and the scale with which observational health research can be done when there's a common data model, a well-established distributed data network, and importantly, open source tooling, and the great potential that this kind of network has for ophthalmology. And I just want to take a moment to thank my co-authors, without whom this work would not be possible. Thanks.
Great. Thank you so much, Cindy. Next, we have Dr. Kathy Sun from the University of California, San Francisco. Thanks, Kathy.
Thanks to the organizers. So I'm excited to talk about some of my work from fellowship at the University of Miami, replicating the glaucoma clinical trial using real-world data. Next slide. So just an overview for some of you who haven't thought about glaucoma surgery in a while. So we were looking at tube shunts versus trabeculectomies, and tube shunts come in two different flavors. So valve like the Ahmed and non-valve like the Barbelt, and trabeculectomy, which has been around for longer. You're physically creating a hole for aqueous fluid to flow out. So in the initial tube versus trabeculectomy study, which was conducted by Dr. Steve Getty from 1999 to 2004, it was looking at the safety and efficacy of tube shunt surgery versus trabeculectomy in patients who had had prior cataract surgery and or trabeculectomy. Nearly a decade later, we decided to try to replicate the study using IRIS registry data, and the initial impetus was to try to have larger sample sizes to perform subgroup analysis that were sufficiently powered. In the initial study, they randomized 212 eyes, one eye per patient, to either a Barbelt 350 or a trabeculectomy with mitomycin C. And in the IRIS registry study, we used data from 2013 to 2017, and that identified about 85,000 patients who had a tube or a TRAB by CPT code. And we applied inclusion-exclusion criteria to get us to as close to the initial RCT. And that severely decreased our sample size to 419 patients who had 1 year of follow-up. And about 56% of those patients received any type of tube shunt, and 44% received a trabeculectomy. So there were some significant differences between the two groups, mainly that in our IRIS registry study, we had to include all tube shunts because we did not have access to the operative notes, so it was unable to differentiate who had an Ahmed versus a Barbelt. Similarly, we did not know if patients received mitomycin C, but it was standard of care, so presumably yes. There were more missed follow-up visits in the IRIS registry as expected with real-world data. There was no standardized IOP measurement method. And as I mentioned, we used data nearly a decade after the original RCT, and that study did have some influence on the increased adoption of tube shunts. And there were significant baseline differences between treatment groups, mainly with race, prior laser, prior cataract surgery, and more patients in the tube shunt group had prior trabeculectomies than in the TRAB group. But I did want to highlight that our baseline intraocular pressure medications were similar in both groups, in the tube and the TRAB groups in both studies. So the primary outcome of the initial RCT was failure using a composite outcome. And so at 1 year, there was greater failure rate in the TRAB group at 13% compared to the tube group. And this was statistically significant and carried out to 5 years. And this result really drove the increased adoption of tube shunts. In the IRIS registry study, we did not find a significant difference between the tube groups, but the TRAB groups were fairly similar, 13% and 16%. We were also interested in looking at intraocular pressure and medications. And so in the initial RCT, there was a 50% reduction in intraocular pressure from baseline to 1 year. And similarly, in the IRIS registry study, we also saw that both groups had pressure reduction of 46%. In terms of the number of medications used, it was lower in the trabeculectomy group compared to the tube group in both studies. So as I mentioned, one of the major limitations was that there was no unstructured data like operative notes and other clinical notes. There were differences in baseline variables between the tube and TRAB groups. We didn't have the sample size to do propensity score matching. At the time, dates were provided by week and year only, but that has since changed in the IRIS registry. Medication laterality was unfortunately not available. And as with all real-world data, IOP and vision were not measured in a standardized manner. So in conclusion, our IRIS registry study found that there was no difference in the tube versus TRAB failure rates at 1 year, whereas the initial RCT found that TRABs had a higher failure rate. We did find similar intraocular pressure, medication reduction, failure rates at 1 year in the TRAD groups in both studies. And this really suggests that the IRIS registry can be used reliably to assess real-world surgical outcomes, given that we were comparing similar cohorts. And as I mentioned, some of the differences could be due to the inclusion of non-Barvelts, greater severity in the tube eyes, and real-world practice pattern differences. And we think that RCTs and EHR data should both be used and offer valuable insights. Thank you.
Great. Thank you, Kathy. Thanks to the entire session for a great set of talks. So now we'll have all the panelists come back on. And certainly if there's questions from the audience, please do type them into the chat. I'd be happy to ask them, but otherwise, certainly a lot of questions for all of you. Kathy, I'll start with you. You have done real world data studies in both retina and glaucoma, which is great. Do you think that there are some unique challenges that you face in glaucoma when it comes to certain types of data that maybe we don't think about as much in retina, for example, curating IOP data or others?
Yeah, that's a great question. I think with exam data, we face similar limitations in that there isn't standardization. Certainly with intraocular pressure, there are different measurement methods. And so like with the RCT we looked at, it was standardized to applanation, whereas you are taking all types of measurements done by both technicians and physicians. But I think in general, methods apply to both retina and glaucoma, and it's really thinking about how do we, it's difficult to emulate an RCT with real world data. So what is the best approach to using this data to be able to answer a question, even though we can't match on all of the same criteria? And I think that was a really important message and challenge that we came across. And there are definitely things that I think we would do differently in the future.
Yeah, great points. And Kathy, you bring up the point about sort of matching. We did a real world clinical trial emulation with the CAT trial and tried to use propensity scores. And so, Brian, I think this question is for you. I think one of the issues we ran into when we did our study is that really, even with such a large data set, such as IRIS, when we tried to use these propensity scores, we could not find enough patients in that database that really matched the patients in the trial. Do you think that's why patients don't use or people don't use this more often in real world studies? Are there other obstacles that are getting in the way?
I think, yeah, but I also think the fact that the propensity score being used, it can be informative. So if you're having trouble with your propensity score, then I think, to really get the best comparison, you need your propensity score matching to work. And if it doesn't work, you got to reevaluate what either the question you're asking or at least the groups you're asking within it is. I think specific to the study you did, it's so hard to match dosing intervals for the real world to what happens in clinical trials that made it very difficult for you to find that sample size. I'm not, obviously I didn't run the study, but the propensity score is tougher in that situation just because it's so winnowed down, just because how we treat people in the real world is so dramatically different from clinical trials. So.
Yeah, I think those are great points. And, we thought maybe it was just because we were using an older study where there was monthly treatment. But really, when you think about it, even a lot of our current retina clinical trials do use dosing protocols that we don't use in the real world as much. Yeah. And so it becomes very difficult to match patients. Cindy, great talk about network studies. I think one of the things that I've wondered about this is kind of broader application. So a lot of times the cohort and the outcome have been defined based on more structured and semi-structured data elements. Is there an opportunity to do similar studies where maybe you create a machine learning algorithm that looks at clinical notes for a specific data point and then deploy that across the network?
Yeah, these are all areas of innovation that folks in the Odyssey community are engaged in. As you heard from Michelle, the Eye Care Vision Research Work Group is focused on bringing in more ophthalmic specific variables like our eye exam data into the OMAP Common Data Model. And then there are also specific other work groups focused on NLP and geocoding and bringing other, types of variables in so that we can develop richer phenotypes and look at richer outcomes.
Great. And Michelle, you listed kind of some of the challenges that ophthalmology has seen in adopting a common data model. What do you think sort of the one or two biggest ones are that we need to tackle in order to be most effective?
Yeah, that's a great question. And it's something I've been thinking about recently. And I think one thing that could be very helpful is if we could get consensus about what is this sort of minimum set of data elements that would be collected during an exam. And, can we standardize those as much as possible and get them mapped and get them in, concepts and have them available in as many, standardized terminologies, but also in as many data models and standards as possible, not only OMAP, but things like FHIR for those of you that are more familiar with some more interoperability standards, and making sure that those are interoperable. And there's a lot of folks at NEI that are working on this and also working with the government on some, potential policy or regulatory initiatives that could help with this standardization, so that the data at the front end is also more collected in a standardized way and more complete so that it's available more in the back end. But this not only helps research, it also helps clinical care and quality reporting and all those other things as well.
That's a great point. I think getting that sort of buy-in and engagement from clinicians that it isn't just about research, that I shouldn't say just, but it isn't only about research, that it's also really about clinical care could help how data is collected. Devinder, you had a great talk on a machine learning algorithm that looked at previously treated eyes. And as you mentioned, some of that treatment effect maybe isn't the same as what we see in clinical trials because of just having a more refractory set of patients. Is faricimab being used commonly in treatment naive patients in Australia? Is it possible that we could look at a similar type of algorithm in sort of treatment naive eyes and see potentially a greater kind of fluid reduction response than what we see in some of these refractory cases?
Yeah, thank you. Definitely, it's possible. We were limited in collecting data, so we were very much at the coalface trying to extract data out of electronic health records and OCT scans, which is onerous and manual. So we were limited by that. But yes, that's certainly possible. Faricimab is being used treatment naive eyes, but exactly how many, it's very difficult to tell.
Yeah, I think even with some of the studies we're doing in the US, we're finding that the longer that it's been available, our treatment naive cohort is growing, but initially it was really mostly treatment experienced eyes that we study. And Erin, congratulations to you and your entire team on the great work that you've done with the Bridge to AI project. You mentioned something really that caught my eye, is that you're really trying to create a diverse data set of patients that are sometimes not often studied, especially in clinical trials. And you showed kind of some of the race breakdown and other factors that you're looking at to really kind of make your data set as diverse as possible. Are there challenges that you faced in that, specific kind of techniques that you've used to make sure you choose certain sites? How have you gone about that?
Yeah, that's probably been one of the hardest parts of the study is getting the recruitment in. In fact, I think a lot of people, including myself, wasn't sure if we were going to be successful in hitting our milestones for recruitment. So one of the things that we did is we really worked with people who have been doing these types of studies for a long time. People like Cynthia Owsley at UAB, who's the lead of the data collection in this project. What her and her team had recommended was that we would send out letters in the mail to targeted groups of people. So what we did is we went into the EHR from these three health systems at UCSD, UAB, and UW, and we extracted like basically every patient that had ever been seen in those medical centers for the last 3 or 4 years. And we stratified them into these 4 buckets that we're trying to recruit. Actually, it's more like 16 or 32 buckets that we have because we want to achieve nested balancing. And we are what we're doing is we're sending out letters to fill those buckets, and as soon as we're done filling a bucket, we stop sending those letters. So we stop. It's a very much targeted recruitment strategy, and so that means that we're like oversampling in some certain areas because the recruitment and participation rate is very, very different across these different strata. And so that's really the only option that we had to sort of achieve that.
Great. Well, thank you all for a great session.
If I could really quickly, sorry.
Sure.
Very quickly. I just wanted to congratulate Michelle and Cindy on their study. I had not realized that they had used high dimensional propensity scores in their study. And so kudos to them for bringing it to ophthalmology. And that's definitely the direction that we're going. So I'm appreciative to them for doing that.
Well, great panel and great set of talks. So thank you all very much. And next, before we move to the next session, we will have a presentation from our sponsor, Genentech.
Retinal disease can pose a significant threat to patients' vision. At Regeneron, we are compelled to help protect and preserve sight. Through our proprietary technologies, we continue to address the urgent needs in retinal health. Our commitment to innovation drives potential solutions for these challenges. Central to our mission is our collaboration with the ophthalmology community, which helps to advance patient care from clinical trials to practice. Regeneron's commitment to retinal eye diseases includes wet age-related macular degeneration, macular edema following retinal vein occlusion, diabetic macular edema, diabetic retinopathy, and retinopathy of prematurity. We take pride in scientific developments which help address unmet needs in retinal health, and our passion to elevate patient care is demonstrated beyond measure. Regeneron Ophthalmology, leading with innovation, guided by science.
Great. Thank you to our sponsor, Genentech. We'll get started with the next session, which is on retinovascular disease and uveitis. And our first talk is from Dr. Michael Ip from Doheny Eye Center, and he'll be speaking about faricimab for retinal vein occlusion.
Thank you, Durga. Great program. It's a real honor to be here, so thank you for the invitation. On behalf of my co-investigators listed here on, I think, the next slide. Yes, it's a real pleasure to present this talk. My disclosures can be seen here on the next slide, please. I don't seem to have control of it, so I'm just going to verbally call out for the next slide. Yes, next slide. Okay, so no, go back, please. Stay there, and then I'll cue the next one up in a moment. So, as my title slide suggested, I am going to present some real-world cases. But first, I think it's worthwhile to review the registration trials for faricimab for retinal vein occlusion. So there were 2, Balaton for branch retinal vein occlusion and Camino for central and hemiretinal vein occlusion. And within each one, there was a 1-to-1 allocation ratio between eyes receiving faricimab 6 milligrams every month times 6 versus a aflibercept 2 milligram monthly times 6. And the primary endpoint was measured at week 24, which was the end of that fixed treatment interval, which will allow for a head-to-head comparison between the 2 drugs. And then following week 24, all eyes were then assigned to faricimab in a modified treat and extend regimen based on OCT and visual acuity criteria. And I'll present some of the data at week 72 following the modified treat and extend portion of the clinical trial. Next slide, please. And you can see here the visual acuity results at the end of the fixed interval treatment phase of 24 weeks. And you can see that for both Balaton and Camino, there was non-inferiority of the faricimab 6 milligram compared with aflibercept 2 milligram. With respect to some of the anatomical outcomes at the end of this fixed interval phase, which again allowed for a direct head-to-head comparison, if you go to the next slide, please, what we can see, forward one more. You can forward, yeah. So here you can see, no, back one. Back one more, right there, hold it please. Right there, you can see that with respect to the proportion of patients with complete absence of macular leakage, that for both BRVO and for CRVO, there's a higher proportion of eyes that had this metric of absence of macular leakage. So we can see that at the end of that fixed interval phase, there was an anatomical advantage of faricimab compared with aflibercept. Next slide, one more. And when we extend the visual acuity results out all the way out to week 72, you can see that the visual acuity results are very similar for the eyes that were switched to faricimab, whether or not they were prior faricimab or prior aflibercept arms. And the median number of injections was less than monthly. So for Balaton, it was a mean of 4, and for Camino, it was a median of 5 injections. Next slide, please. And the central subfield thickness results show that there was robust and very quick reductions in central subfield thickness, both for BRVO and for CRVO, and this was sustained all the way throughout the extension period to week 72. Next slide. And this slide shows that the portion of patients on this modified treat and extend interval all the way out to week 68 showed that more than 57% of patients in the Balaton and more than 45% in Camino achieved an at least Q12 week dosing interval, showing that there is good durability of faricimab in this condition, both BRVO and CRVO. Next slide, please. Forward one. And the safety profile looks excellent out to week 72. The safety results from baseline to week 24 have been shown previously, but these results here between week 24 and 72 are relatively newer data, and we don't see any difference in the adverse effect profile compared with what was seen from baseline to week 24, with low rates of endophthalmitis, retinal vasculitis, and retinal artery occlusion or embolism. Also, the intraocular inflammatory events are quite low and balanced between the aflibercept arms and the faricimab arm within Balaton and within Camino. Next slide. And so, as I promised, there's a real-world case, courtesy of Ivan Sunier, who graciously provided this case. It's very interesting. So I'm going to show it here, which is the patient at baseline, 59-year-old female with a central retinal vein occlusion. She underwent a lot of treatment prior to switching to faricimab, and I'll show you what happens in this case. So if you go to the next slide, you can see this is the OCT at baseline with a central subfield thickness of 687 microns and a visual acuity of 2100. The patient was then treated, if you go to the next slide, you can see this patient was then treated with a number of anti-VEGF injections as well as dexamethasone. And following the dexamethasone, next forward one more, you can see that there is some reduction in the central subfield thickness, but there's still quite a bit of residual. The patient continues to get anti-VEGF and a combination of dexamethasone. So if you go one more, you can continue to see that there is some residual edema, even on the combination of ranibizumab and dexamethasone. And then the patient is injected with faricimab, and then you start to see some good anatomical results once the switch is made. So if you go to the next forward one more, and then one more after that, you can start to see disease control, anatomical control start to develop as faricimab is injected. And at the same time, the intervals are lengthened and these good anatomical results are maintained. One more. And then another. So now we're out to 12 weeks with excellent anatomical control in an eye that was previously quite recalcitrant to anti-VEGF therapy in combination with dexamethasone. So next slide. So what this shows is that the visual acuity gains can be maintained through week 72 in the Camino and Balaton clinical trials. CST reduction can also be maintained throughout this period of time. Anatomically, it was noted that more participants achieved the absence of macular leakage with faricimab compared with aflibercept at the end of the head-to-head 24-week period. More than 45% of the patients had at least Q12-week dosing with faricimab, so good durability was shown. And faricimab was also shown to have a good safety profile through week 72. And I think the real-world case really demonstrates a robust efficacy in a patient that was previously recalcitrant to anti-VEGF and dexamethasone treatment. So thank you.
Great. Thank you so much for the great talk. Next, we have Dr. Rahul Khurana.
Thank you very much to the organizing committee. I'm excited to present here. Does COVID-19 cause retinal vascular occlusions? Here are my financial disclosures. None of them are relevant to this talk. And I wanted to start with a case. This is a 26-year-old healthy male who presented to our clinic with the classic signs of a central retinal vein occlusion. Patient had no past medical history, no ocular history after a significant workup. Now, if the patient had told us that this had happened while he had been at a Cleveland Browns football game a few weeks earlier, and he asked whether that was associated, I think we all agree that maybe being a fan of the Cleveland Browns may be deleterious to your mental health. Association is not causation. But what if the patient had told you a few weeks earlier he'd lost his sense of smell and was diagnosed with COVID-19? And did that cause it? And this is actually a patient we saw in the pandemic. This was about April to May in 2020 when a patient like this who came in who had COVID-19. And we know that when we look at the medical literature, we know that COVID-19 can cause vascular damage and thrombus formation. We know it induces the fibrinolytic pathway, setting off a cytokine storm, damaging vascular endothelium and causing embolus formation. And we've seen in our clinical literature higher rates of deep vein thrombosis, pulmonary embolism, myocardial injury, and stroke. And so it made a lot of sense that this could be causal. And when we look at the literature, we know that the retinal findings of COVID-19 have been a little controversial. Early in the pandemic, there were some erroneous OCT findings in normal patients that were later found to be not really, pathologic. But since then, there have been some literature reviews, and there was a recent paper that showed a nearly 9-fold increase in retinal microvascular disease, such as retinal hemorrhages, cotton wool spots, microaneurysms. We've also seen OCT work has shown evidence of retinal capillary occlusions. There have been cases of acute macular neuroretinopathy and also cases of paracentral acute middle maculopathy. Finally, there have been case reports of vascular occlusions, including artery occlusions and retinal vein occlusions like the patient that I presented earlier in the talk. But when we want to prove causality, we want to move beyond temporality. Does the cause precede the effect? And the Bradfield-Hill criteria involve 9 criteria to really see if we can prove causation. And so let's turn back to our original question. Does COVID-19 cause vascular occlusions? Now, we've had many case reports in the literature reporting various cases of vascular occlusions after COVID-19. We've also had some very compelling case series. There was a report led by Avni Finn, which showed Hemi and CRVOs in young patients with no known risk factors, like the patient we initially presented, that made it very compelling. And there was a large cohort study from the Kaiser Permanente group that showed a higher rate in higher rate of retinal vascular occlusions after COVID-19. In fact, this paper looked at over 400,000 patients in the Kaiser Permanente system, and what they found, they looked at the rate of RVOs and RAOs within 6 months after a positive COVID-19 test. And what they showed was that there was no increase in the rate of retinal artery occlusions, but what they did show, there was a higher rate of retinal venous occlusions after a COVID-19 test. Now, even though the study was large, there were only 65 cases of RVOs in the study. And I think one of the challenges in proving causation is, how do you prove incidence when the causation is high? And no, Dr. Evil, there have not been 1 million cases of COVID-19, but instead we have seen that there have been over 776 million of confirmed cases of COVID-19 across the globe. So proving causation, even in these larger studies, is much challenging. And so to really answer this question, we really had to turn towards big data. And I think when I say big data, I mean clinical registries. And we did a study looking at the Academy's IRIS registry. As many know, is the largest subspecialty registry in the United States that involves over 80 million unique patients. And a really nice analysis led by Charles Lee and Flora Lum, we decided that if the hypothesis was that COVID-19 indeed causes retinal vascular occlusions, we should have seen a higher rate. And we calculated the number of retinal vascular occlusions in 2017, 2018, and 2019, and developed models what we should have expected to see in 2020, 2021, and 2022. And what did we find? Essentially, we found that retinal vascular occlusions did not increase during the pandemic. You can look at the retinal of BRVOs, CRVOs, BRAOs, and central retinal artery occlusions, and there was no increase. When we look at the patient that I presented earlier in the patient with a CRVO, you can see that, let me just zoom in on that. You can see that the purple line shows that there was actually a decrease early on in the pandemic, and even later it never increased over various statistical models, even at the lower confidence intervals. Now, we know that there was a suppression of ophthalmic care during the COVID-19 pandemic, and more severe diagnoses made a higher percentage of our clinic visits in practice. So even though the number of vascular occlusions did not increase, it made up a higher percentage of our clinical visits, giving us an impression there was a higher rate. And this observation actually was also seen by another study led by Dr. Dariush Moshfeghi, looking at the Vestrum Clinic, looking at 65 private practice retina clinics that showed not an increase in the absolute number of vascular occlusions, but rather a higher percentage. Now, even though both studies are compelling, they did have limitations that they didn't look at COVID-19 tests. And really, the definitive paper, I think, came out in ophthalmology this year from our colleagues in Korea. And this was a nationwide population study of over 8.5 million patients. It was led by Dr. Lee and Dr. Kim. And what they found was that when you looked at within 60 days of a positive COVID-19 test, there was no increase in the rate of retinal artery occlusions and retinal venous occlusions after a COVID-19 test, showing that there was really not an increase after that at that time. So I think in summary, when we look at the data, there have been multiple cases and case series of vascular occlusion after COVID-19. Unfortunately, causality is extremely challenging when you have a very high incidence. And at this time, causality has not been proven in large databases. Thank you for your time.
Great. Thank you for a great talk. And then next we have Dr. Michael Singer speaking to us about real-world outcomes of XIPERE.
Thank you, Durga. I'm excited to be here this morning to talk about the real-world safety and efficacy of suprachoroidal injection of triamcinolone acetonide injectable suspension, or XIPERE, for uveitic macular edema in clinical practice. Here are my financial disclosures. Of note, I do consult for Bausch and Lomb. All right, sorry. We want to determine the durability of suprachoroidal triamcinolone in patients with uveitic macular edema in real world. So we wanted to evaluate it not only in terms of its incidence, but also in terms of how it affects intraocular pressure in uveitic macular edema patients. So what we know is obviously suprachoroidal triamcinolone acetonide is a corticosteroid indicated for uveitic macular edema. The study focuses on the duration of effect and safety of real-world practice of these patients in terms of not only how long does it last and what are the side effects, because those are the things everybody wanted to know, because obviously the Peachtree and Magnolia studies, as good as they were limited in terms of the number of patients that they enroll. So what did we do? We went to the IRIS database and we looked at both the IRIS and Komodo database, and we looked at patients from January 22 to December 2023. Patients had to have a diagnosis of uveitic macular edema. They had to be over the age of 18. They had to have a diagnosis of infectious uveitis 12 months prior to the receipt of suprachoroidal triamcinolone acetonide. Patients, for the durability, patients had 24 weeks were followed up for durability. And then we did a sub-study looking at patients up to 48 weeks in terms of intraocular pressure. And the elevation was recorded in respect to the nearest baseline IOP prior to injection administration. So we wanted to see, you had a shot, how long, what happened to the IOP over time. So let's look at the results. So essentially what we found is that 87% of people did not require an injected or implanted corticosteroid by 6 months. This is very similar to the results in Peachtree, where 86.5% of people did not require rescue therapy by week 24 as well. And you can see the numbers essentially overlap each other. When we look at any corticosteroid, not only injected or implanted, but even topical steroid, 75%, 3/4 of patients didn't need any type of corticosteroid rescue within the first 6 months over time. Now we're going to look at a little bit of a smaller database, because one thing was interesting to know when we looked at those patients, we wanted to look at people who were followed over time. And what was interesting is when you look at the baseline demographics, and this was really similar to the durability analysis as well, the numbers were relatively stable. What was interesting was 43% of people had a diagnosis of glaucoma or ocular hypertension prior to the administration of suprachoroidal triamcinolone. So what we did was, and 28% of patients had a baseline intraocular pressure of greater than 22 when the study was started. So interesting, when we looked at this, what happened is that you had 14% of people who had an IOP greater than 10. You had 1.1% of people who had an IOP greater than 25, and you had no people who had an IOP greater than 30. So these data were very similar to what you saw in Magnolia in terms of being 10, but when it came to 25, it was actually better and nobody over 30. And these rates were consistent with recently presented data by Danny Momo and companies at ASRS, where we looked at a smaller survey of doctors who use a lot of this medicine, where you've pretty much shown the same amount of IOP changes over time. What we really want to know is when is it going to happen, right? We need a rule book. We need a way to follow these people up. So I dug a little deeper, and what we really found was, we looking at the 10 millimeter increase, that 5.8% of people you could find as early as 6 weeks, 10% of people you would find it at 12 weeks, 13% of people you could find it at 24 weeks, and 14.2% of people you could find it at 48 weeks. We dug a little deeper on the greater than 25, and it turns out you didn't find anybody at 6 weeks. You found people two patients of, there weren't many, only 4. 2 of the 4 were at 12 weeks. 1 of the 4 was at 24, and 1 was at 48. So in conclusion, only 12% of people with uveitic macular edema required a subsequent injection of implanted corticosteroid 24 weeks after a single suprachoroidal injection. Only 14.2% of patients experienced an IOP greater than 10 at 48 weeks in real world, despite 43% of people with a history of glaucoma. 1.1% of people developed IOP greater than 25, and no patients had IOP greater than 30, which was much lower than the Magnolia clinical trial. So you want to consider these patients with a history of glaucoma or ocular hypertension, because it seems to be a safer steroid. In terms of the rules for following up, what I would recommend is you follow up these patients at 1 month, 3 months, 6 months, and every 3 months to capture the 10 millimeter increase in IOP and capture any of those people, the small as they are, that have IOP over 25. I want to thank you for your attention.
Great. Thank you for a great set of talks. We'll have the three of you all join us for questions. If there's any questions from the audience, would of course love to hear from you. Otherwise, I can ask some questions as well. Dr. Singer, great talk on Xipere. I think one of the things I thought was interesting was in Peachtree, my understanding was that patients were treated at week 0 at baseline and then also at week 12. Is it correct that that's not what seems to be happening in the real world for the most part?
Absolutely. So the interesting thing is I didn't touch on that just because of time, but in real life, you really had about 6% of the respondents do patients at week 12. And I think what happened is initially when the drug was approved, we all wanted to follow the rule book, right? You typically say, this is how they did it, we should follow it. And then some of us, and actually there's an article that just got published about real world experience from the early adopters, that everybody started with, we're going to give a shot at 3 months. And really quickly, they realized that that's unnecessary. So, they just kept pushing it as far as they could. And now people really think based on data like this, that you're able to go, in 75% of people, you're able to go 6 months without using any steroid. And, in terms of implantable steroids, 87% is a pretty high number. So now I think that's pretty much abandoned for people who use this. And if you're a new person who wants to start it, I don't think you need to reload the people. I mean, I think what's nice about this is because it's sequestered, it's going to stick around a lot longer. And I think the chance of you getting an IOP spike is smaller because less medicine gets to the anterior chamber.
Great points. And what do you think the next steps are in expanding on this study? Do you think imaging data is in the future in terms?
Absolutely. The IRIS database is wonderful, but it's been a while before it could actually come up to speed. And my understanding is only been under a year that they have imaging data. And we'd love to know is how long it lasts is nice. How dry do people get, right? Do people get dry over time at every single visit, or do we have to tolerate fluid like we're starting to tolerate fluid in a lot of our second generation anti-VEGF medicines?
Yeah, great point. So hopefully those will be the next steps. Rahul, great talk. Why do you, I mean, I have a couple questions. I think it's really useful for counseling our patients. Has anyone looked at any of these associations with the vaccine in particular? Get that question a lot, not just in terms of the infection, but actually getting the vaccine.
Yeah, there's been, I think, 3 really good pieces of evidence that I think make us comfortable that it's safe. And I think a lot of these, that's almost like a own talk in itself. But I think there's 3 really good works. I think work read by Rishi Singh looking at the Trinex data showed a very low incidence of RVO after the vaccines, similar to getting after Tdap and other types of vaccines. So that was really good. But really the definitive paper, again, came from that same paper from Korea, which showed that, after the vaccine in Korea, when they looked at it, they didn't show any increased rate in RVOs, RAOs, RVOs. And then there's I think, a global VAERS program that showed a very low incidence. So I think when it comes to vaccines, the hard part in vaccines is that you have healthy patients, and if something happens, they want to immediately attribute causality. But the problem of determining causality is that in vaccines, the numbers are even greater. We're talking about billions of vaccines given versus, millions of COVID-19 cases. So even if you have some cases, proving causality is challenging. But I think the data so far from our big analytic platforms has shown that it is safe regarding that. So.
Great points. And why do you think that there was a difference in your study results compared to the Kaiser results for RVO specifically? Is it just kind of different methods, or were they, they're using a smaller population as well?
Yeah, I think one of the challenges is the Kaiser study was done very well. They had over 400,000 patients, and they propensity matched them. They controlled for a lot of different things. But I think one of the challenges is when your incidence number is so small. So even though they showed a higher rate, they only had 65 cases of RVOs. And again, how those fall could determine a higher number rate that's there. And so I think the Korea study, which looked at 8.5 million patients, out of a population base, not a specific, area, I think is more compelling. And I think I tend to believe that data more than the Kaiser data. But I think the question's still not answered. I think we need more and more studies to see if that signal is strong. I think one of the challenges with COVID-19, especially with RVOs, is that it makes just so much clinical sense because we've seen it in so many other parts of medicine of higher rates of vascular occlusions, venous occlusions, that we would think it should also be here. But I think as we're looking at the larger data, we're just not seeing it true at this time. Maybe other studies will show it, but at this point, I'm not sure if I think the data has not shown it yet.
Okay. Yeah, great points. And I think really helpful for counseling our patients. Dr. Ip, sorry, I'm being a little more formal with the two of you to differentiate the Michaels, but great talk on RVO. And you presented some really great, compelling clinical trial data. I think one of the struggles we often face with real world studies is then we see different results for a lot of different reasons than what we see in the trials. For example, in RVO and the faricimab studies, I anticipate we'll see very, very different treatment regimens. We certainly most of us don't treat our RVO patients every 4 weeks for 6 injections on the onset. So there's going to be a difference in treatment protocols. Are there other challenges you see when we try to design a real world study on this? I know some of them are already ongoing.
Yeah, I think that's a good question, and I think that really applies to just about any disease we're talking about, whether it's neovascular AMD, diabetic macular edema, or in this case, retinal vein occlusion, which is you have to design a clinical trial to answer a particular question, right? And then in the real world, we use it in a different way, and it's very, very typical. And so I think when you're designing a retinal vein occlusion trial, you almost have to, at this point, based on the previous clinical trials, go head to head for about 6 months, and then you get your answer in terms of the relative differences between the drugs. And then after that, when you get FDA approval, then we can do these real world analyses. And so for retinal vein occlusion, we haven't yet had the benefit, for example, of far retina, far wide, where it's been looked at in the real world for neovascular AMD and DME. Those analyses are forthcoming, but they're not available yet, so I really couldn't share that. So when I went to present the real world case, I had to present only at this point the registrational clinical trials. So again, really to get to your question, I think a lot of these real world analyses, just by the definition, have to be done following the context of the clinical trial. I do commend the design of Balaton and Camino for at least after the first 24 weeks, they did switch to sort of a real world scenario, but still within the context of a clinical trial where everybody was switched, no matter what their original assignment was, to faricimab, and they used it in a treat and extend type regimen based on OCT and visual acuity. And at least in that sort of investigator-driven treatment protocol within the context of a clinical trial, it showed that faricimab really was able to maintain good durability, good visual acuity results, and good anatomical results.
Great. Yeah, thank you. I think all great points, and the extension data, as you mentioned, is certainly very compelling. Well, thanks to the three of you for great talks and a great panel. We'll move on to some of the abstract submissions that we have now. And first, we'll be starting with Dr. Sophie Frank, who will be presenting on treatment effect of fluid volumes and vision in treatment naive versus pre-treated neovascular age-related macular degeneration.
Thank you very much. So today, we all know neovascular AMD. We keep treating our patients, but even though we give more and more anti-VEGF injections, do we have success with our patients? Because up to 80% of them develop fibrosis or atrophy. We know from clinical trial analysis that all 3 types of fluid, intraretinal fluid, subretinal fluid, and PEDs, do have an impact on visual acuity, especially intraretinal fluid in this analysis. But when we actually look at the real world, in this real world analysis from the FRB, the Fight Retinal Blindness Registry, we can see that only intraretinal fluid had a significant effect on BCVA. So why do we have these differences with our data? We have limitations because clinical trials actually have strict inclusion and exclusion criteria, such as exclusion of any geographic atrophy or fibrosis within the eyes of the patients included, and also a lot of clinical trials only include treatment-naive patients. In the real world, things look differently. So we actually want to, sorry, one slide was missed. No, never mind. We actually wanted to look in this analysis into the comparison of treatment-naive patients and pre-treated patients in neovascular AMD. So for this purpose, we included 286 eyes with neovascular AMD showing presence of SRF and/or intraretinal fluid at baseline. And those patients then all received anti-VEGF injections. Also, BCVA testing was performed and OCT imaging was acquired. After 1 month, all patients came back and received again BCVA testing and OCT imaging. And lastly, we looked at the difference in BCVA and the absolute and relative fluid response rates within the central 1 and 6 millimeter areas of the OCT. So when looking at the baseline results, we can see that the treatment-naive patients had actually a lower BCVA, higher IRF volumes, and lower PED volumes. But then when we look at therapy response, we can also see that we had higher gains in BCVA in the treatment-naive group compared to pre-treated eyes, with around 4.3 letters gain compared to 2.2 letters in pre-treated eyes. Now, on the right-hand side, you can actually see the fluid response of all patients. The blue line is always representative of the treatment-naive patients, and the orange line for pre-treated patients. You can see that all of them actually responded, but the blue line of treatment-naive patients does seem steeper in most of these graphs. When we now look at the absolute difference, so month 1 minus baseline, we can see that we had a significant effect on intraretinal fluid in the treatment-naive eyes. So we had a better absolute response in these eyes. But we still had these differences at baseline. So we also wanted to look at the relative difference, which is visible here. When you look on the right-hand side, on the graph, 1 means that 100% of fluid was responsive of anti-VEGF treatment. So here in this analysis, we found that all 3 types of fluid showed a significantly higher response in treatment-naive eyes compared to pre-treated patients. Now, to conclude, we saw that treatment-naive eyes had lower BCVA at baseline, higher IRF volumes, and lower PED volumes in the treatment-naive group. We also saw that functionally we had a greater gain in BCVA in those treatment-naive eyes. Morphologically speaking, we did see higher response rates in the treatment-naive eyes, not only for IRF, but especially there, but when looking at relative response rates also for SRF and PED volumes. So we do ask the question if there is a kind of resistance building within our patients who have been treated before, and how should we respond to this question. But lastly, the most important thing is that we still need to actually quantify fluid volume to have an optimal patient treatment and individual patient management for future optimal outcomes. So thank you very much for your interest, and thank you to my team for their support.
Wonderful, thank you. Next, we have Cora Berdejo presenting on comparison of visual and anatomical outcomes in patients treated with Eylea 2 milligrams versus Vabysmo for AMD between 2022 to 2024 in a district hospital in the United Kingdom. Thank you, Cora.
Hello, everyone. Thank you for the opportunity to present our recent analysis comparing these 2 different drugs for age-related macular degeneration, Eylea 2 milligrams and Vabysmo. This presentation will walk through our real-world data analysis gathered from patients treated at a district hospital in the UK from 2022 to 2024, focusing on the comparative outcomes between these treatments. To set the stage, let's briefly review AMD management. So the National Institute of Clinical Excellence, or NICE, recommends anti-VEGF agents for treating wet AMD. Sorry. Eylea and Vabysmo are both widely used, though with some not difference in outcomes and effectiveness. Our study's objective was to directly compare the visual acuity and central retinal thickness outcomes in patients receiving these two treatments, aiming to see which may offer greater clinical benefits. Our method involved a retrospective analysis over 22 months, examining a cohort of patients who receive either Eylea 2 milligrams or Vabysmo injections. We collect data on patient demographics, the number of injections, as well as vision acuity and central retinal thickness measurements before and after treatment. Statistical analysis help us determine mean values and assess difference in vision acuity and central retinal thickness outcomes between these two groups. Now, let's turn to our results. In the Eylea group, our sample is quite small, 12 patients. The maximum gain in visual acuity reached 41 letters, with an average improvement of 10.2 letters. CRT reduction in this group averaged 32.9 microns. In contrast, the Vabysmo group with 18 patients had a maximum VA gain of 34 letters, but a higher average gain of 12.8 letters. The mean CRT reduction in the Vabysmo group was significantly greater at 58.6 microns. These results offer a few key takeaways. While Eylea patients achieved a slightly higher peak vision acuity gains, the average improvement was more consistent across the Vabysmo group. Furthermore, the greater reduction in CRT observed with Vabysmo suggests it might be more effective in reducing retinal swelling and overall retinal thickness. Since a primary goal in AMD treatment is to minimize retinal thickening, these findings imply that Vabysmo may offer better control over retinal pathology and could lead to improved visual outcomes overall. In conclusion, our data suggests that both Eylea and Vabysmo are effective treatment options for AMD. However, Vabysmo may provide superior benefits in terms of consistent VA gains and more substantial CRT reduction, which are both critical in managing AMD and preserving patient vision. These findings are valuable for guiding treatment decisions, especially in contexts where CRT reduction is a priority. Thank you for your attention.
Wonderful. Thank you so much. Great talk. Next, we have Suki Bernstein presenting on real-world data of 5-year comparative analysis of various modalities of treatment outcomes in BRVO, efficacy of visual acuity gains, and CMT reduction in a district hospital setting in the United Kingdom. Thank you, Suki.
Yes, hi everyone. I'm Suki Bernstein. I'm one of the medical students from the University of Buckingham. I have no financial disclosures. So today I'm going to be talking about branch retinal vein occlusion. I know all of you here are experts in the matter, but just in case there are other medical students, this condition was first described in 1877 and it refers to the obstruction of branch retinal vein occlusion at an arteriovenous crossing. So the mechanism that's happening is basically compression of the vein that causes turbulence in the blood flow, and then it causes thrombus formation. So why is this important for this study? Well, first of all, the region is very metabolically rich, meaning that any sort of disruption to it can cause quite pronounced symptoms. And then secondly, well, just because it's common, it's the second most common retinal pathology. So that's why we focused on this condition. Next slide, please. There are many causes and risk factors. All of you guys here probably know them better than me, but hypertension can be a cause of this as well. And dangerously, it's also an asymptomatic condition, meaning that it makes detection and monitoring quite tricky. And so therefore vascular workup is important. Next slide, please. So sorry, a little bit of a dry slide, but this just shows the treatment and management outcomes. So basically, the Royal College of Ophthalmologists suggests to measure visual acuity. And then from there, depending on whether there is edema and hemorrhage, you would initiate treatment. The mainstay of this is anti-VEGF and steroids, so dexamethasone, both of this being intravitreal injections. Next slide, please. And so this is just for reference. So these guidelines are just sort of talk about the different regimens and the dosages. Next slide, please. So this is what we did. We took 11 groups, a total of 102 patients over 5 years, with a few exclusions, including glaucoma, diabetic, and other eye conditions. And we looked at visual acuity, CRT, and the number of injections, and we recorded this. Next slide, please. So we followed the Royal College of Ophthalmologists and the NICE guidelines as well. So, and we looked at the different monotherapies and compared them to laser treatments and other multimodal approaches. Next slide, please. And this is what we found. We found that ranibizumab shows the best in visual acuity gain, while combi anti-VEGF provides the greatest CRT reduction. Interestingly, though, we found that Orthodex actually increases CRT instead of reducing it. Next slide, please. So yes, this is just saying what I was just mentioning just now. Next slide, please. And so our conclusion is that ranibizumab proves to be the most effective in improving the visual acuity, that dexamethasone as a monotherapy has actually negative outcomes. Next slide, please. And interestingly, we compared this with other studies, and we found that what we found was in line with them. We had a slightly bigger cohort size and therefore more power in our statistics. Next slide, please. And these are just my references. Thank you very much for listening.
Wonderful. Thank you to the three of you for great talks on submitted abstract presentations. We'd love to have all of you come on. And if there's any questions from the audience, happy to ask those. Otherwise, I'll ask a few questions. Sophie, great presentation. What are the next steps for, I'm sorry, Sophia, what are the next steps for your analysis?
Well, for now, we looked at treatment regarding BCVA and fluid, and next up we would like to actually look also at microperimetry and effect on actual retinal function, not only in the center and the main vision which BCVA captures, but we also want to look at the perifoveal and parafoveal regions in the study cohort as well. But we only have month 3 data of this analysis, so we need to have a lot of data looked at in the time, so it might be a while until we can present that data.
Great. Well, we look forward to seeing that. And Cora, you know, when we study some of these branded drugs in the United States, there's quite a bit of selection bias in terms of who is getting them. You know, we talked a little bit about treatment naive versus treatment experienced patients and some of the other talks, but there's also for us the issue of insurance coverage. You know, not every patient can get a branded drug, and so it can be there's selection bias based on multiple factors. Do you face similar issues in the UK, or are most patients able to get Eylea 2 milligrams or Vabysmo if they want it? You know, I know those are the 2 agents you talked about.
Yeah, here in England, we don't have these restrictions, so most of our patients, they can have any of these treatments. So obviously we have pathways and we have a first line of treatment, but if it's not working, we always can switch for a different drug. So yeah, it's not many restrictions as far as yes, only if they are approved for the condition we are treating.
That's great. And I think it sort of emphasizes the importance of doing these similar studies internationally in multiple different populations, because there, you know, are different challenges that we face depending on the healthcare system we're working in. So really appreciate the insights from the UK. And Suki, great talk as well. Are you thinking about doing a similar analysis and including faricimab for retinal vein occlusion? Are many people using it? Is available in the UK now for RVO specifically?
Yes, I think that was the idea. It was just licensed, so we will be looking to do that in the near future.
Okay, great. Well, are there any other questions from the audience, or if you all have any questions for each other? If not, then thank you all so much. And with that, we'll be concluding the program actually. So thank you all for a great morning. This was really a great opportunity to discuss real world studies across the spectrum, from understanding different data sets and advanced applied methods for real world studies, and some of the many great studies that have been done in the past year from around the world. Thank you to our wonderful faculty who joined us this morning, and for a great keynote lecture from Dr. Michael Chang. Of course, a special thanks to my co-chairs, Dr. Rishi Singh and Dr. Brian Vanderbeek, as well as iVista Medical Education and Studio Clark, for making this such a smooth program. And of course, none of this would have been possible without our wonderful sponsors. Thank you to Apellis, Astellas, Genentech, Regeneron, and REGENXBIO for their generous support of this program. And to our attendees, please complete the post-test and evaluation. There's a QR code on the screen. Your opinion is really valuable to all of us, and we look forward to seeing you all next year. Thank you.